enhances recovery and strengthens patients' trust. Interventions such as evidence-based maternal care, standardized infection prevention bundles have significantly reduced morbidity and mortality across the globe. Application of research evidence in our practice also promotes accountability and enhances patient safety. It protects patients and it even shields you, the practitioner, because when you give care that is based on research evidence, it means that you are giving care that you can defend. You are giving care that is defensible. If we apply research evidence and data, our practices will also be consistent with what is known across the healthcare continuum. Research also ensures that our decisions are supported by standards, validated standards, rather than individual preferences or institutional habits. Nurses and midwives, for you to walk into a ward and they will tell you that this is how we do this. This is how we do this. And I've always said I'm happy that I worked as a nurse for a number of years before moving into the classroom, because it also gives me some understanding of what we do as nurses. It's safer for both the practitioner and then the patients. Innovations in nursing and midwifery is rooted in research. Through systematic research or systematic inquiry, practitioners are able to uncover new approaches, refine ongoing or existing approaches, and respond effectively to emerging health challenges. Many groundbreaking practices, ranging from kangaroo mother care, neonatal resuscitation, nurse-led community-based interventions, were all born out of research. Evidence or research evidence turns practitioners into innovators who drive continuous improvement within the health system. Now, having underscored the importance of research evidence in our practice, we cannot also run away from the fact that there are challenges. At the micro level and then even at the macro level, there are a number of challenges. So despite the overwhelming importance of evidence-based nursing and midwifery practice, integrating evidence-based nursing and midwifery practice into clinical practice faces significant challenges. Nurses and midwives often struggle with understanding and then applying evidence-based practice due to systemic barriers such as limited training, insufficient leadership support, lack of motivation, and inadequate resources. Sometime 2016, when we started engaging in research, myself, Prof, and then some few of our colleagues did a research on, that is published actually on BMC, on mother-to-child transmission of hepatitis B. Extent of knowledge among midwives and physicians in one of the regions in Ghana. Now, what did we discover? We discovered that all the nurses, or all the midwives, and then the physicians, they all had fairly good knowledge on hepatitis B transmission. That was fine. Now, as a midwife, the other thing that you ought to know is that if a woman is hepatitis B positive and gives birth to a child, it means that the child has to immediately be given the vaccine and then the immunoglobulin. Is that not it? Now, what we discovered was that even though they had adequate knowledge on hepatitis B, most of the midwives did not know that if a woman is hepatitis B positive and gives birth, this vaccine or these two drugs has to be given immediately. And we also asked them their sources of knowledge on hepatitis B transmission. And we were told by almost most of them that they only heard about this during their training. And almost half, or 49.something% of the midwives told us that since they left school, they have not attended any workshop on mother-to-child transmission on hepatitis B. What it means is that they will be limited in being able to do this. But it is not their fault that they are limited, but they have not had CPDs, or they have not had exposure to this kind of information, so they wouldn't be able to do it the way they're supposed to be. So limited training is one thing that we need to all come to terms with. That is preventing us from implementing evidence-based nursing and midwifery practice. Aside these micro-level barriers that I have mentioned, we can also agree that there are structural and then cultural barriers that also exist across our health system. These obstacles hinder the realization of evidence-based nursing and midwifery practice that has the potential of improving patient outcomes. And once we are not able to implement these things, it means that we are also going to disadvantage our patients, or we are going to escalate the already existing inequalities in health delivery that we have. Another challenge in implementing evidence-based nursing and midwifery practice is inadequate knowledge and skills in our emerging young nurses and midwives. And all of you who have done the undergraduate program will agree with me that our curricula that we use to do the training have limited courses, or there's limited exposure of our students to critical appraisal skills, to how to search for literature and on academic writing at the undergrad level. And these are basic concepts that are very important in equipping our young graduates with the kind of knowledge that they need in order to be able to deliver evidence-based nursing and midwifery practice. Now, critical appraisal, literature searching, academic writing are concepts that are basically embedded in postgraduate and PhD studies. But truth also be told, all those engaged in master's and PhD studies are not those who are coming back to the world to work in most cases. So we have to refocus our training to ensure that those who are coming to work in the world are actually given the kind of skill that we want them to have, so that they can be able to deliver evidence-based practice to our patients. Now, other things we need to do to bridge the gap is also the fact that we need to equip our nurses and midwives with some research literacy. We need to have some intentional programs that exposes our practitioners to some basic concepts in research, or some basic skills in order to carry out some applied research based on practical things that they have seen in the world that can inform their practice. If we do that, we are sure that we are going to develop competent evidence-based nursing and midwifery workforce. And the last point I want to touch is also research collaborations. Currently, what is happening is that nurses that are in academia, we do a lot of research, but we keep our research. Then those in the world, what they also do is that they come and give their care and they go home. But we all understand, or we all agree, that the research that we are doing, even in academic institutions, is very relevant to the practice. So we will need to have collaborations, so that once you are doing research and you want the research to inform practice, it means that you should have someone from the world being part of your research team. Because essentially we are not doing solo research, we are doing collaborative researches. So we need to collaborate with our colleagues in the world to do some of the research that we are doing. And if we do that, we are almost bringing our research findings to the world. And we then have to encourage all our health facilities to create evidence-based nursing and midwifery platforms. That once you are collaborating, the evidence should also be kept here. Once the evidence is kept here, there should be ways, or there should be programs that will allow dissemination of the evidence that has been discovered so that it can be put to practice, because we agree that the research data is important, but what are we doing to ensure that this data that we get from research is also implemented? Madam Chair, to conclude, I want to state that the application of research evidence and data is not an academic exercise as we see it, but it is a moral duty of all of us. Our patients deserve care that is safe, care that is current, care that is grounded on scientific truths. So if we embrace evidence-based practice, we are going to be able to elevate our profession. We are going to be able to strengthen our delivery, and we are going to contribute meaningfully to national and global health outcomes. Thank you very much.
Thank you very much, Dr. Nashna, for highlighting the relevance of generating local evidence and then applying this evidence also in our local context as well. I rewarded with you in 10 minutes because you came very early, but for Professor General, I'm going to give you only 5 minutes to make your submission. And Professor General, you don't have to mount the podium, you can still be here, and then let us hear from you your initial submission. Thank you, sir.
It's like you've just massacred me, and I want to mount the podium because I'm a teacher. A teacher must be a teacher. So with your permission, Chair, thank you very much. Yes, 5 minutes. I don't know if you can help me with the projection since my time is five minutes. Great, thank you very much. So it's my pleasure to be here to speak to us on burnout and mental health issues and towards the well-being of us nurses and midwives. And my name is Samuel Ajololo. A lot to say, but I'll just move. Okay, so just a quick, my overview will look like this. Defining this will not be necessary since we all know this already, but I just want to highlight that yes, please go back. Go back, go back, go back. Great. So, yes, this will be our outline. Defining mental health, we are familiar with. Next, please. Next. So one thing for sure is the connection between mental health and burnout. That burnout is the ingredient for mental health issues, okay? So today, although these two are supposed to be discussed, for the sake of time, I'll focus on burnout so that we can move on quickly. Next, please. So burnout is an occupational epidemic. Can you move to the next slide, please? No? Okay, that's fine. So worldwide, a lot of people, nurses, physicians, pharmacists get affected. We do know also suicide is one of the issues that connect us significantly. Please move to the next slide. Yeah, so burnout, suicide, mental health issues are just siblings. They just interconnect with each other. Okay, so but we do know that a lot of people, more than half of healthcare workers experience burnout. But how is the situation like in the Ghanaian context? So in Ghana, I just brought some studies like my colleague was mentioning earlier, there are a lot of studies done on burnout among healthcare workers, nurses, and midwives in this country. So I intentionally brought the authors and the title of the study so that if you have any questions about this, you can reach out to them. So that you don't say that I'm quoting wrongly, I'm just bringing it. So if it is wrong, it is from them, it's not from me. So in one study in CHAG facilities in Greater Accra, about 3 out of every 10 midwives and nurses reported burnout. 3 out of 10. Among psychiatric nurses, we have almost 2 out of every 10 reporting mild to severe depression. We have about 3 out of every 10 also reporting mild to severe anxiety. Now we have 4 out of 10 reporting mild to high stress. For another study involving midwives and nurses, 58% reported different levels of burnout with respect to emotional exhaustion. 55 reported poor personal accomplishments, and 38 reported depersonalization. So we know. So it's not new. We know this. We know what is happening. Maybe what we don't know is the consequences. Can you move on to the next? Okay, great, thank you. So burnout manifests in 3 dimensions. The first one is emotional exhaustion, which is where you feel drained and depleted of your emotional resources. And then we have depersonalization, where you feel detached. Okay, you lose connection with even your colleagues and the patient you work with. And then there is reduced personal accomplishment, where you question your own ability as a nurse or as a midwife and the value that you are bringing to the profession that you've chosen to practice. So these 3 things can manifest. One of them, 2 of them, or all the 3 of them can manifest in one person. So you can imagine how pathetic it will be to have even one of these manifesting in you as you are providing care to people. Now, what contributes more to burnout? We do know staffing issues. Staff. Few nurses, few midwives, more patients. Then administrative burden. And for those of us who are not computer literate, with the LIMS, introduction of the LIMS, I can imagine how much extra work we have to do to input data. And now that the GIMS is coming, maybe the interface may be different. We have to learn again. So these are all administrative issues that can affect us. Then moral injury, of course, realizing that you're unable to live up to the value that you are supposed to live up to, can also contribute to high burnout. Next, please. Right. Then we have workplace violence and bullying. The way we bully, and of course we know, especially the in charges, the way they can bully us, we just didn't die. But we have survived. You know, this also contributes to burnout. And then stigma in assessing care can also complicate the issue of burnout. Okay? But how do you know that you are going through burnout? How do you recognize burnout? Next slide, please. How do you recognize that you are experiencing burnout? Or, you know, it's not like a malaria attack that you can know that, oh, I'm feeling feverish. No. These are behavioral and some other signs that you can even confuse with other things. In behavioral terms, you begin to withdraw from your colleagues, and this is where I want us to pay attention to, because this is where the literacy comes in. Begin to withdraw from your colleagues. You tend to have a lot of absence, missing work, or rescheduling, looking for someone to replace you almost quite often. And a reduced productivity and difficulty concentrating on the things that you're supposed to do. So instead of 2 milligrams, you are giving 10 milligrams. Physically, you have a lot of fatigue, you experience sleep disturbances, you have headaches, your immune system becomes very weakened. At the emotional level, you are characterized by a sense of anxiety or irritability. You feel overwhelmed, extremely overwhelmed, like there's a lot on your plate. Meanwhile, there's nothing on your plate. You are less motivated to do things, like very lethargic and very sluggish in the things you do. But emotionally, you are tired. You don't feel like talking that much. In terms of the work you do, your satisfaction is reduced, quality of care is compromised, there's so much errors that you make, and there's high turnover, which is you intending to leave the place of practice. So you begin to see some of these things, then it means that we must begin to take action to address, because the impact on patient care and safety becomes very high. And I know a colleague here who works so much in the area of medication errors and patient safety and co. And I can understand that he's probably being influenced by the idea of burnout and other issues that nurses and midwives experience. So this we do know. But I think the thrust of the issue is also about the individual level or the interventions, how to address this burden or burnout issues at the workplace. And I've proposed a 4-level individual intervention strategies that can work for you. One is mindfulness-based intervention. So here, the answer is very simple. Make friends with some Indians or some people from Asia, Japanese, Chinese. They do a lot of meditation. And just learn how to meditate. It helps a lot. Yes. At the individual level, meditation is key, so do that. Then you can also seek help from professionals where they can give you some counseling and CBT. Education and training becomes also a very important tool for you to manage your stress and also develop some coping strategies and communication training. And then physical health promotion, regular exercises can be helpful, adequate sleep can be helpful, and of course nutrition. Those of you who want to save, you are always saving. Even what to eat, you are thinking about what to eat, meanwhile you are saving. What are you saving for? The future is now, there's no future anywhere. But you must be alive to be able to have that retirement, so you need to eat well, okay? So these basic things can be helpful. Then at the organizational level, we can do job and tax modifications, restructuring the work to reduce the demand. Staffing issues can be addressed, and this is where our in-charges, our bosses becomes important. We need flexible working and scheduling period. Maybe when we get there, we may begin to work remotely using telemedicine or e-health tools. We can also work on the physical work environment. Our workstations as nurses, midwives, it's not nice. We don't have sofas to even relax. There is nothing, just hardcore chairs and tables, okay? So can we also, as workers, contribute small money to buy some of those things on our own to relax? Because that's where we get the money from. So we can do those contributions. Adequate resources, preventing of violence at the workplace, and then involving nurses and midwives in the things that happens on the ward. Okay? Problem solving when there's a problem. You don't impose the solutions on them, get them involved. In developing policies and planning, because once they're involved, they feel energized, they feel belonged. They see themselves as active, not passive agents in the whole system. So here, then GRMA and co as trade unions can also play a key role in addressing that. Next slide, please. Negotiating safe working conditions, and over the years, I know this association in particular have been very, very forceful and very vocal in this way for the members. We also need protection from retaliation. The way doctors protect each other, we too must learn to protect each other. Okay? Otherwise, nobody will do that for us. Yeah. We should be fighting for mental health benefit, and I know it's also on the agenda of the association for some screening interventions free of charge. And to me, it makes no sense that the healthcare worker must pay to get basic services. It makes no basic sense. So let's fight to reduce any cost that we have to pay if you have to get some of these things. And of course, system policy change, which I know this association too is also working so hard on that. So if we do some of these things, to sum up, in summary of to-do list, at the individual level, you can take yourself through some basic yoga, mindfulness exercises. At the organization level, evidence-based programs can work, and at the union level, negotiation skills, advocacy can be helpful. We do know that seeking help is a sign of strength and not weakness. So please, let's seek help if we need to do so, because mental health is as important as physical health. Thank you very much.
Thank you very much. I gave Professor Ajuru 5 minutes to do his presentation, but he ended up spending almost about 12 minutes. But whilst I was thinking of ending his session, I remembered my Reverend, who would mount the stage and would be preaching. And when you prompt him, Reverend, it's time, he will tell you, do not rush the Holy Spirit. Do not rush the Holy Spirit. So it was really difficult for me to end the session. But then, unfortunately, my colleagues here are saying that they are academics, and if I force them to sit and present, then I'll be inducing burnout. So because of that, they have pleaded that they want to mount the stage and do the presentation. So next on the bill, we have Dr. Margaret Kokiba to speak on the role of AI in patient care and its impact on national practice and education. Thank you, madam.
Thank you very much. The chairperson of the program and Madam President of our association, I want to crave your indulgence to stand on the established protocol to convey my thanks. So I'm not only honored, but I consider it a privilege to initiate the conversation on AI in use in our profession. AI is currently a buzzword, but I hope it is safe for me to speculate that most of us here still cannot appreciate very well what it really is. So I would just want to introduce us to what it is, and also let me acknowledge that I'm a novice in the field, but because of AI, I'm able to stand before you and to help us to initiate the conversation. So maybe some of the terminology may not be very familiar because AI is here to be mainstreamed into our practices in full blown. So I hope I'm safe to go. Thank you. So AI, basically, which is artificial intelligence, refers to computer systems that are designed to perform tasks that would ordinarily be performed by human beings and require the intelligence of human beings to carry out such tasks. And when we say intelligence of human beings, we talk of things like being able to reason, to make decisions, to learn, to recognize patterns, and to solve problems. And of course, you know that in our daily work, this is what we do. We try to learn, to to solve problems, to make decisions about ourselves and the work that is given to us. So AI currently uses data and algorithms. And algorithms, somebody will be asking, what are these things? Because so far as we are concerned, algorithms are basic, either mathematical or maybe some pathways. Yes, basically it's similar to that. There are a set of rules that are developed by the experts in computer science engineering for the purpose of helping us to make decisions, and that would have been done by human beings, right? And AI is very, very critical in our work today because it helps us to make clinical judgment and improve our efficiency and the outcomes for our patients. Now, there are so many tools of AI that can assist in healthcare, and they include those that power imaging and diagnostic processes, to chatbots that we can use to give patient education, to voice-to-text documentation tools that can help us to free our hands from writing and then give information we document, to where we, the academics, can use to facilitate teaching and learning and make it efficient. So for us, nurses and midwives, AI presents to us opportunities but also responsibilities for our profession. It has the potential to increase access to the quality of care, strengthen the health systems, and support the training of the next generation of nurses and midwives, especially in countries like Ghana, where the staff's strength is low, as Prof has just said, and the quality of training, as Gilbert has mentioned, does not cover all the things that we require. Evidence in particular, which is critical in safe, efficient care for us. So AI comes in handy when with all these deficiencies, right? So for direct patient care, how is it useful to us? It's reshaping care in several meaningful ways. Like I indicated earlier, diagnostic is faster. If you have AI-enabled X-rays, it can readily differentiate between pneumonia and tuberculosis, and that takes you directly to managing without having to waste time or doing trial and error, because most of us here know that sometimes we treat pneumonia for a very long time before we come to the point to say that no, it's not pneumonia, it is tuberculosis. And AI comes in handy in things like that, right? And it's also very useful in early detection and prevention. Very predictive models can be designed by AI to help us appreciate the, the emergence of new diseases, and even identify outbreaks, epidemics, and so on. So once it is fed with information and you give it one or two information, it can quickly do an analysis of the trend, the rate at which it is receiving this information, and tell you that you might be having an epidemic at your hand. So it's very predictive. We do no more need to carry people to travel from one end to the other to be able to gather the data for us to be able to make those diagnoses and determine those things. Once I sit in Bolga and feed the system, and you feed it, the people at the head office information center can see the graphs moving up and down and can tell us that the way things are happening in this part of the region, we should be alert. So AI is very, very critical for us as health workers in determining things like that. For care, when COVID came, those of us who were watching, we saw what was happening in developing countries like China. We even had the robots that were performing some of the tasks for us. So those mechanical tasks that AI can do, It will save us free, and then we can provide the emotional care of empathy and compassion. Because sometimes as a result of the stress of the mechanical walking up and down to give care, we get burnout, become frustrated, and as Prof indicated, we now let it out on our patients who actually need us to heal. So with AI taking over the task, we can actually do a lot. As I indicated earlier, if I don't have to go and sit by the table to write, and I just put more or less maybe something attached to my uniform, and I'm administering a drug and telling me that I'm administering this dose of drugs, and it is feeding it into the system. By the time I finish administering the drug, I have also finished documenting, and I have saved a lot of time, and myself and the patient are all safe. Calibration, dosage calculations, AI can do precise calculations for us and reduce medication errors and many other things for us. AIs can help us. Right now, sometimes we schedule things manually and we are not able to follow through. And we even forget because we are looking for the papers, or we are searching through the files to see where did I save that file, where is it? With automated AI things, not only can we schedule our rotas, but also appointments of our patients for home visit, for who is supposed to come. We can do all those things. We try to do the capitation of health, right, to prevent everybody from going to the hospital and what have you, isn't it? And we failed, and that is because we were depending on ourselves. Assume we used AI. I'm sure that me, I will not get up and come to the hospital as and when I like, and so, or I will not leave maybe Savulugu Hospital and run to TTH because I think that is where I can find the best doctor. AI can schedule all these things, and even if I have to go to TTH, I'm scheduled to the extent that I will not go at the time when some other people are scheduled, and then there will be over a crowd on the healthcare providers, and they're not able to give us. So AI is very, very important for all these things that we do as nurses. We've been asked to really, really summarize our work, so I'll be leaving out a lot of things just so that we can meet the time, and then we'll carry on in the discussion. When it comes to education in particular, now with AI, and sorry if I'm going to be level on this because I'm an educationist, it's more exciting to talk about that. Just imagine a student sends you their work, and then you feed it into a system, and you tell it, I want to know the quality of this work. From if a student is supposed to produce this type of work all over the world, what is the quality of the work that the person has produced, ranging from 1 to 10, rate it for me. It is for undergraduate level 100 students, so take note of that. Besides looking at the content of the work, please AI, also check the grammar. Are they speaking at the grammar level? Now recommend to me, what are the gaps in these students' ability to learn? So what should the students be learning? Not only have I marked that work, I have diagnosed it, and I know what the student will be learning next. My work is done. My teachers, are we here? Let's not go and be scratching our heads again. AI will tell you all that in just a matter of seconds. And it will tell you whether the student went and took it from AI or they did it themselves. Thank you very much. Recently, my students present their proposal for research, and somebody had as high as 87% AI. So I called, I said, I've been telling you people, that's luckily for me, I'm very savvy. So by the time you bring this work, I have already thought of how I'm going to get you. And I just forwarded the whole report. So it actually helps you to force them to learn. And I told them, you are getting a 0. Unfortunately, then I had to do that anyway because this person never learned a thing. So AI is very, very important for us, for our skills. Hello. I'm happy that I have significantly initiated the conversation. Madam Chairperson, I believe my duty here was to ignite the conversation. Thank you, my job is done. Yeah, have a blessed day.
Thank you very much, madam. Thank you. So, hello, colleagues. I'm just curious about one thing. Are you contending the 0 score? Or you are contending the 0 score? Okay, because she's saying they should use AI and she's scoring 0 and okay. That's just the beginning of the conversation. That's just the beginning. Thank you very much. Thank you. So let's welcome Ms. Patience Kariga to talk on nesting and climate change, preparing for health impact. Madam, you have 7 minutes.
7, thank you. I think I can make it a slideshow. Then let me put my laptop. Okay, thank you, Prof. Moderator, for giving me the opportunity. Madam Chair, I humbly request to stand on existing protocol to also deliver my presentation on climate change and health. And in view of this, I humbly and respectfully acknowledge all protocols present. Good morning, ladies and gentlemen. My name is Patience Kariga. I'm a lecturer in the Department of Dietetics and a registered dietitian by training. In fact, I'm truly excited to be here today to lead this important discussion on climate change and on health. And in fact, this is a remarkable platform, and I can say I'm highly honored to be invited to lead this. I know you could have chosen a nurse to deliver this presentation, but your decision reflects the value you place on the contributions of other health professionals in the system in the health system. And to me, this is I can say this is a powerful contribution to interprofessional collaboration. And I applaud the nursing fraternity for this opportunity and then their strong leadership. Okay. So art is projected, nursing and climate change, preparing for health impact. Are we really prepared to take up the task during climate crisis? We'll get to know that today. Just to share that my interest in climate research ignited about 2 years ago when I was involved in collaborative and partnership works with both local and international organizations or partners. And since then, I've grown a heightened passion to participate and then also conduct climate research and advocacy. And I can say that day in, day out, I wake up trying to see how I can understand the pathways to which climate change impacts on vulnerable groups, especially pregnant women, children, disabled, and then the elderly. So by way of introduction, in fact, in the past, climate change was seen as a geophysical phenomenon or any natural phenomenon. If we ask the geographers, they will tell us that. But what do we see now? It has evolved into other multidimensional challenges that are impacting on health. We can talk about economic, social, and the most important, our nutrition and health challenges, and all of these have an impact on human life. In fact, it is increasingly recognized as a major global health emergency. And the World Health Organization has warned that climate change is one of the biggest health threats that is facing humanity. And when you look at it in the 21st or the 20th century, it's part of the 3 C's that is impacting on human life, which includes COVID-19, conflict, and then climate change. It is damaging our key fundamentals of health, including clean air, water, food, and then shelter. And its direct and indirect impacts are all impacting on or contributing to illness, injuries, mental distress, whilst also increasing malnutrition, which is in fact a very big issue, because we are already faced with food insecurity, and now with climate change, it's worsening, and day in, day out, we are recording cases of malnutrition, include micronutrient deficiency, malnutrition, undernutrition, and the like. What is the UN saying about climate change? They define it as a shift in long-term temperature and then unpredictable weather patterns. And such shifts can be natural as a result of natural processes, or it can also be caused mainly driven by human activities. And since the 1800s, human activities have been the major driver of climate change. So when we are looking at the causes, I'll explain further. It is also seen as a wicked problem. It is because it's complex, causes multidimensional challenges, and has no single solution. And that is why it's defined as a wicked problem. It's also seen as a mega trend because it is slow but powerful global trend, and that has far-reaching and long impacts on our health. So how do people feel and think about climate change? Looking at it, data that we generate, graphs, trends, and records that we get from predictive weather services such as weather forecast is able to help us think about climate change. And if you look at the graph since the 21st century, you've seen that there have been sharp increase rise in temperature. And you can see that. And how do people feel it? We feel it based on everyday's impact or everyday's weather experiences that we experience. And if I should ask most of you about the changes now, you hear people talk about extreme heat, talk about drought, erratic rainfall patterns, storm, hurricanes. So depending on where you find yourself, the geographical location also have an influence on how we experience climate change. So where are we now? In Africa, let's refer to the Intergovernmental Panel on Climate Change. They have identified Africa as one of the most susceptible continents to climate change, with projections indicating that a potential average annual temperature increases of 2 degrees by the mid-21st century compared to the late 20th century. So our globe is warming up. It's warming up, and the only planet for now that supports life is Earth. And we all have to contribute to see how we can manage this problem. So what are the causes? Earlier I mentioned that human activities is the main driver of climate change. And looking at it, I'm not a geographer, but let me try explaining how it happens. It's about increased emission of greenhouse gases such as methane, nitrous oxide. We can also talk about increased emission of carbon dioxide. And these greenhouse gases, it goes around the sun, attracts or traps the heat, and then moves it into the globe. And that is what is contributing to global warming. And what are some of the activities that is contributing to the emission of these greenhouse gases? We can talk about burning of fossil fuel to produce electricity, transportation. We can also talk about most of our industries that are relying on highly powered plants or machines to produce in high quantities. We can talk about deforestation. In fact, we all know the cycle. Carbon dioxide that we produce is being absorbed by trees. They process it and give us back oxygen. So if we are cutting down the trees, what will we have to absorb the carbon dioxide again? We can talk about rearing of ruminants, such as cattle. After consuming the grass, the process the food goes through, after breakdown, methane is produced. And as they belch, we have more methane in the atmosphere. Fertilizer usage would contribute to nitrous oxide. So all of these are the human activities that contributes to climate change. There are other natural processes which include volcano activity, solar variations, and natural climate crisis. So based on the collaborations I've been involved in research, what do our people also perceive as the causes of climate change? So some focus group discussions that I have participated in, our people think it's punishment from God for our bad deeds. Others also sees it as a reason for, it's caused by wrong decisions regarding the people who choose to lead us. And I quote somebody's statement that truly we also hear people relate it to current chieftaincy issues. They say that before the current chief was enskinned, the rainfall pattern was good. There was no drought and food was plenty. But after he was enskinned, now the rains have reduced. In fact, that's what people think, and it's very important for us to capture some of these perceptions because there are some of behavior change theories that supports this, because our perception informs behavior. And for us to adapt to mitigation and adaptation measures, we need to know what our people think about climate change. So how does it impact on human health? Its direct and indirect impacts on human health greatly. Increased heat. In fact, it's just like when we sleep in the night, you having more than 10 blankets around you. And works with pregnant women, they have reported that, in fact, they don't always know what to do to themselves, especially in the night. If you sleep in the room, the heat will trap you. If you come out, you are at risk of vector-borne issues like mosquitoes biting you and all of that. So my interests have been to see how we can at least mitigate this among vulnerable groups, as I've mentioned, such as pregnant women. So there's direct impact. Extreme heat can lead to ill-related illnesses such as dehydration, heat stroke, and then the like. We can also look at its impact on indirect consequences such as food insecurity, because erratic rainfall patterns will contribute to low food production, which will trickle down to household food insecurity. And in no time, we'll start recording a lot of cases of malnutrition. All of this will also trigger social dynamics, and especially women are always at the forefront, because if there is no food and there is no water, women spend much of their time trying to get that. And this will limit their access to health care, especially antenatal care service. In fact, there are a whole lot of factors or issues that climate change contributes to. These are some studies that have been done in the area, and then they linked heat to mood and emotion. So extreme heat have an impact on mental health, just like my prof had already presented. And a study that was conducted by Thompson, he has reported that each 1 degree increase in temperature can contribute to 1 to 2 rise in suicidal rates. So there's a link there between when we experience extreme heat and then mental health. Indirectly, climate change also contributes to forced migration, preventing people from living in their natural habitats and have to move, with a pronounced risk of mental disorders due to stresses before, during, and after migration. Talking about the direct impact on health, let's also look at our health systems and the determinants of health. So when you look at it, climate change will disrupt how health care facilities operate. We can look at a world that is overcrowded, where there is decline in indoor air quality. It will impact on disease prognosis. It will also have an impact on recovery, and also on our health infrastructure. Even we, the care providers, are also at risk. Working in such an environment, the risk is high for us. The social dynamics, such as reduced equity, where there's already existing gender inequality, and that will continue to worsen some of these issues. Who are the vulnerable groups? We can talk about pregnant and lactating women, infant and young children, the elderly, persons with chronic diseases. rural and those in agric-related communities, low-income households, and persons with disability. So now let's look at our role in climate change. With all that have been mentioned, we know that nurses play a significant role when it comes to improving our health system. In fact, you form the largest workforce within the health sector. We can talk about you being frontliners, the gatekeepers of our health system. And with regards to economic and national development, in fact, you are contributing so much, and then your role cannot be overemphasized. We really recognize that. But we also have a lot of responsibilities, just like the few I've mentioned. What I want to reiterate is that during climate crisis, your responsibilities will expand, and then your roles will become more critical. You are already providing care, but there are certain times that you have to do more than we are doing now, which means the health systems should also be prepared well to meet up with these crises. So regarding clinical care and early detection, it's expected that we should play roles in identifying and managing heat-related illnesses, to monitor vulnerable groups such as pregnant women, infants, and elderly, to treat climate-sensitive diseases. Regarding health education, it is important for us to teach heat avoidance, especially at the community level, hydration, safe sanitation, to promote climate-smart nutrition and seasonal meal planning, which you have a role there to support the nutritionists and dietitians to do this, to also encourage ANC attendance during climate disruption. So some of these services, as of now, we have to look at how we can provide the services and then be more intentional about bringing in climate-sensitive approaches. If we've been holding ANC clinics in an enclosed area, when the weather is so hot, it would be nice we move out of such situations. So we have to look at cultural, specific, or sensitive approaches in which we can deliver our services in a very simple way, and also considering the climate. In fact, nurses also and midwives have a close connection with the patients and then the community. So you can lead very well regarding community engagement initiatives by supporting community sensitization on climate risks, work with leaders, promote clean cook stoves, and then reduce indoor pollution. These are some federal roles such as surveillance, talk about disaster preparedness, leadership, sustainable health facilities. So who protects the nurse? Who cares for the caregiver? So in providing your duties, the line of duties, is also very important for us to consider these main points, such as providing adequate PPE. I'm very excited your leaders are here and then can consider that. Improving working conditions, ensure continuous training, especially in service training that are more climate inclined. Can also look at strengthening occupational health safety policies, enhance facility infrastructure, and provide proper compensation and insurance. In fact, these challenges are not new to the nursing profession. However, climate crisis has the potential to deepen them, making workload heavier, resources more strained, and working conditions more difficult. So I'm just bringing them to draw our attention that we have so much to do in preparing to meet climate crisis. What are some of the key recommendations for nurses? In fact, we have to look at the curriculum for our training and education. It should be more climate sensitive, because for us to be able to contribute to building climate health, sensitive health systems, then we have to look at the future professionals that we are training. We need to look at the curriculum, review it to make sure we include other climate sensitive approaches in there. Also in-service training for those that are already within the service, workshops, all of that can support to promote low carbon sustaining healthcare through reducing waste and then also managing some of the equipment that are provided for us to work, supporting research and monitoring, advocate for climate justice and equity for the vulnerable groups, and building emergency and disaster response capacity. So this for all of us. The Sustainable Development Goal 13 looks at climate action, which includes adaptation and mitigation measures. In fact, as I've mentioned earlier, the Earth is the only planet for now that supports life. So it's for all of us to contribute to climate adaptation and mitigation measures. These are some of the adaptation measures, such as early warning systems for heat floods, vector-borne diseases, training health workers on climate-sensitive diseases, improve water sanitation, hygiene, and systems, and then to also mobilize health services to displaced communities, so that we reduce how much electricity we spend on operating our equipment or machines. Solar-powered health, as I've mentioned, promotion of active transport, such as walking and cycling, sort of using our machine, motorbikes and then cars, green hospital energy. In fact, these are some of the mitigation interventions. Madam Chair, in conclusion, climate change is a major health emergency, and nurses play a role in the response. As the largest and most trusted workforce, nurses can lead solutions by educating communities, advocating for policy change, and promoting sustainable practice. Their voices and actions are essential to protect patients, strengthen health systems, and ensure that health remains central in climate discussions. The time to act is now. Thank you.
Right, thank you very much for your presentation. Great, so that we can start the discussion. Madam, I was so excited when you mentioned that you acknowledge the contribution of nurses to the economy, but I was also waiting for you to say that we should be compensated accordingly. So maybe when you mount a different platform, please add that as well. Thank you. Can we have other microphones here so that we can engage? Great, thank you, Professor Joel. Professor Joel, I'm going to start with you. Great, awesome, great. So we know, what we are faced now is migration of nurses. And we are aware there's an association between nurse and midwives migration and burnouts. Now the reality is that there are quite a significant number of facilities losing some of these midwives and nurses because of migration, and I can give you a classical example. So there's this chat facility that I know of 5 perioperative nurses. 3 have already left, and it's left with just 2 of them. And the 2 have intentions to also leave. So you can imagine even now, with the current migration situation, the kind of burnout these individuals are facing. Now, Professor Jolo, how should the health facility leadership balance the immediate retention strategies, and you talk about good working condition, with the long-term workforce planning to reduce migration and its impact on burnouts? Yeah.
Yes, thank you very much. I was privileged to work with the Education Committee of GRMA and also through NMC. We did a work on nursing and intention to migrate, so I'm quite excited about this development. We made some proposals, which I'm happy to share some of them. I think reducing nursing and midwifery migration will require a more systemic and deliberate approach. At the moment, we pay lip service. We are doing so because we have abundance of nurses and midwives who are looking for jobs. So once they leave, we quickly try to recruit to fill the spots. That is a danger to the healthcare system. The reason being that it takes years of practice to acquire certain critical skills. The new ones coming are not ready. So if the old ones are leaving without transferring those skills, then the new ones comes in with so much errors and troubles. So we're in a big trouble. So we have to be deliberate. And the key issue we know, and I don't know why we are thinking we don't know, we know, is the condition of service. That's all. If you can address this, increase people's earnings, affordable accommodation, a very small car to move around. I mean, once we hit this, the people who travel, they don't get it easy there. But comparatively, it's better there. So if you can have those basic things, we are good to go. So for me, that is a bigger issue for discussion. But maybe we can start some apprenticeship program where the young ones who now are in the house not working can be coming to the hospitals to be mentored by the senior ones whilst they are even waiting to be employed. In that case, it will feature like the NACO, is it NACO they call it? Yeah, kind of system. That is a way to reduce the drastic change and to transition properly as people are living. Thank you.
Right, thank you very much, Professor Jerome. Now, before I move to Dr. Machnab to ask specific question on evidence-based practice, Professor Jerome, I still want to stay on this. For example, you showed us some evidence. You showed us real data about the burnout prevalence among nurses, among midwives, and then among other professionals. And obviously, these are segmented studies that are published. What do you think could be the best monitoring mechanism? Because we talk about it, we experience burnout, but if you look at the data in terms of burnout among nurses with a well-structured reporting system that we can refer to and use that one for making decisions, we don't have that in the country. What data collection strategy or approach do you think is feasible in Ghana to monitor nurse and midwife burnout trends? Even though I acknowledge the fact that we have some published information out there.
Thank you very much. So, as you said, what we have there are just pockets of cross-sectional studies. We will need a more representative nationwide study to do that. And this study will take into account different facilities, because each facility and the level of challenge it presents. Kolebu will not be compared to a chief's compound. So we need to take that. We need to take into account the gender of the population, their rank, and other demographics. So we need a deliberate and a more systematized data collection to do that. So the recommendation is to have a nationwide representative survey. And I'm sure the bosses, I know they will say this, but what are you talking about? We give you the chance, you're not doing the thing. I know they'll be doing that. So once we have that data, it's easier then to make a good case about addressing burnout. But at the individual level, one of the things I also realized is literacy issues. People experience burnout symptoms, but they don't know that these burnout symptoms. And once you lack knowledge of something, you are most likely not to look for the solution. So we need, again, ourselves to read, to understand some of the things that can happen to us. The internet can be helpful, but trust me, any idiot can put anything on the internet. So we need to talk to the people who have the insights and the expertise to let us understand what we are going through so that we can begin to look for help. For the men, I beg you, that's why we die early. Please, some of these things, let's take our time and then begin to learn more so that we take active interest and steps in our healthcare. Thank you.
Right, thank you very much, Professor Jones. So Dr. Gilbert Machnab, it was very exciting to hear from your presentation that we generate a lot of local evidences. I mean, it's obvious. Now we have great nurses scholars and we have nursing-specific and midwifery-specific evidence that are generated on a daily basis. Thank God for masters in nursing and PhD in nursing and midwifery. Almost every year we are generating local evidence. And so, of course, it's important we take this into consideration when we are also developing protocols, we are developing guidelines, we are developing some of the interventions for our patient. But what I'm curious to know, Dr. Gilbert, National, is that patients also do have their own preferences. And I'll share with you one classical example of a patient with hepatitis B that I engaged, and she felt that she needed some specific intervention, but the person did not meet the eligibility criteria for that intervention. But scientifically, the patient needed something else. So now, you talk about evidence-based practice. How do we then balance the evidence that you refer to with patient preferences and expectations, as well as taking into consideration the cultural context and some critical clinical decisions?
Yeah. All right. Thank you very much, Prof. I've always said that nursing exists in 3 facets, but and that is we those in education, those in leadership, and those who actually define the profession, those in the world. We could be doing a lot of research in leadership, could be doing a lot of research in academia, but implementation science is where we are lacking. Now, implementation research has to do with how do we transform what we have discovered into what can be implemented for the benefit of our patients. Now, if we want to translate research evidence into something beneficial or into something that can be implemented for our patients, it means that you are going to consider patient-related factors or patient perspective of what is supposed to be done. And it is very key. You are not going to be successful in doing anything for a patient if the patient does not understand what you are doing, or if the patient is not ready to cooperate with you. So what I sincerely think is that we need to pay more attention to implementation science. We need to involve clinicians, hear their perspective. We need to involve patients, hear their perspective, and that will help us develop context-specific, more practical, and more applicable guidelines that we can implement.
Thank you very much. I'm going to lean on this submission to ask you a specific question that I am expecting a specific answer. You know, so GRNM is here, and you are right to say that we are lacking the space of implementation science. It really costs a lot for you to develop an implementation research, and I know most of the studies we do are determinant studies, so we know the problem. Now the question is, how do we then come out with solutions that are more context-specific to address those problems?
Yes,
what message you have for the GRNM leadership in terms of research funding in the area of implementation science?
Very interesting question. I'm sure everybody has an answer to this question, so this is my own answer. Yes, research is very expensive. I mean, and we those who have been involved in research realize that when you are getting a grant and the people giving you the grant are complaining they have no money, finally when they mention the money they have, if it is your first time, you'll be like, this money that you are saying is small. But when you do the work, you will also agree that research is expensive. Now, if we want to ensure that our findings are implemented, or we want to ensure that we embrace or we go into implementation science, what it means is that we have to be very intentional, and we have to have serious budgetary allocations for it, probably develop thematic areas, and then say that we are having realistically this for this amount for this, and that is it. It is the only way that we can drive implementation science, budgetary allocations, and then getting people involved or getting those who can do the work involved, and then we find out ways that we can roll out this. So budget. Very difficult to mention amounts.
Thank you very much. So you mean that the budget allocation should be engineered or commissioned by GRMA leadership?
Sure.
Madam President is here, so I'm sure she's...
Madam Chair, very important information is that next year budget, we have to have something for implementation science, because we have a lot of data, a lot of findings that is out there. But how to transform this into guidelines that are context specific, culturally sensitive, and are embraced or can be embraced by our patients, implementation science, having budget from our association, and then pushing for it to actually be done. Very important.
Great. I see Professor Yolo want to amplify that.
Yes, I'm actually part of the Education and Research Committee of the GRMA, and we have had these discussions severally.
Oh, okay.
We are working on a proposal to the Secretary and the support of the President to have a Research and Innovation Fund to support members of the association who have research ideas and projects that need support to actually do. So
fantastic. That's the way to go.
And it fits very well into the implementation
science. Thank you. So let's move quickly to Madam AI. Madam AI, it's so exciting to hear that you have such great interest in the area of AI. But we're not happy with you when you mentioned that you scored your student 0 for using AI. Do you want to defend that score now?
Yes.
You want to defend the score?
Yes.
The 0 score?
Yes.
So defend, madam.
Thank you for the opportunity. So I had to take advantage of your acceptance of my score to leave the stage. But let me just justify why. It's AI, yes, though it's very, very useful and can provide a lot of information. Remember, this is a growing technology, and it is also having a lot of inaccurate information. So if students just go and pick AI information and bring, and then we just accept it wholeheartedly, it might not be specific to the context. And that is the first thing, the reason why we have to discourage people from using it. Because I could tell whether the information was right or wrong. And so I could easily discard it. But maybe somebody else might not know. Again, the essence of asking a student to do an assignment is to test whether learning has taken place. Now, if this person goes and picks somebody else's work and brings to me, and this person is supposed to have the capacity to interpret the information that they have learned to apply on patients, we are risking the lives of patients. And that is why I have to give them 0, because they are a potential safety issue to patients. So when you give them that harsh alternative, then they are compelled to go back and learn, because I always tell them that, you know what, I cannot compromise with you, because then I'll be compromising with my own health. So when it comes to that, there are no compromises. I know a few of us here, let's say, we'll just add 1 mark. Please, I'm using this opportunity to let us know that that 1 mark may be the mark that is going to cause harm to somebody. So that's why I gave the person 0.
We'll send the message. We will send the message to the students. That's good to hear. But Madam AI, I still want to be here.
Yes, please. No.
So, of course, we expect that. Can we be together, colleagues?
Yeah.
I know you have different opinions. We can take that one to the streets and have that conversation, okay, after the session. But Madam AI, it's important to know that, of course, as we speak now, there are some, I would say, limited number of AI applications. But in the future, you are going to have more. Now, the most critical question is, what future roles do you think nurses and midwives, in terms of competencies, do we need to obtain for an AI-enhanced healthcare system? Because now we seem not to have incorporated the AI into our system, but with time we are going to have that in our system. What competencies do you think we need to develop now as nurses and midwives in preparation for the AI incorporation in our system?
Thank you very much. So we are all holding smartphones. I don't believe that there's anybody here who is not currently holding a smartphone. Unfortunately, we shy away when it comes to developing work-related information, create files, solve issues when using technology. Now, for us to be able to use AI, basic computer skills, we need to learn them. Unfortunately, it is our time, and they will come. I'm not in the world, so I'm not using the limbs and the arms and the what have you. A lot of you are using them. But we still have students who come, nurses who come to school, and you ask them to go and create work, and they are resistant, they are pulling back on doing that. So for me, the first thing is basic computer skills. Now, there are specializations going on, and nursing informatics, for instance, is a specialization in the US and other developing countries. I think that for us as nurse educators in particular, we have to take that course very, very seriously and make sure that that specialization, actually, we can incorporate it into our system. Today, the challenge I have with our universities currently is that we have some people, computer awareness, introduction to computers, and we are all compelled to do that without customizing it to the various professional groups. I think that nurses should make a case to customize the IT technology, right, to our work. Because there are a lot of things, for instance, when you want to incorporate in care study, nursing process and things, you need that. Besides that, we really need to be aware of the data protection issues and security issues when it comes to the use of AI, because we can compromise. And the bottom line is that we need to learn. And if we have to learn, then we have to go back to what Gilbert is talking about, evidence, evidence, and evidence. And it can help us to appreciate why and how AI is very, very important and how we can apply it in our learning.
Thank you very much, Dr. Margaret Kukiba. Is that correct? Great. So, Dr. Margaret, I'm asking you the last question because AI is a very interesting issue and, of course, an emerging area. But people talk about ethical use of AI, and this ethical use of AI, and it's coming up strongly. When you look at the academic environment, it's entirely different from when you move to a clinical environment when some decisions have to be based on automated AI judgments. Automated AI judgments. So for example, I have ever Googled using AI that I need an intervention for A and B, and the response I got were really scary, you know, because of the poor judgments when we are using automated machines. We know our training are regulated, and we know our practice is also somehow managed by the professional organizations. Now my question is, what roles do you think that the regulatory body, which is the National Military Council, and then the GRNMA, which is an association, can also play regarding ethical use of AI, our scope of practice, and also accountability? Because eventually, if you depend on AI for judgment and something happens, you should account for it. So what role do you think these two important organizations or institutions can actually play?
Thank you very much. I don't know how to go. But to start from where you ended, that we need to be accountable. Indeed, we have been hearing of the malpractice issues and what have you. And as you indicated, you generated information and it was all wrong. It means you need to be able to analyze and appreciate the right and wrong of that information. So for the Nurses and Midwife Council, they define the scope of our practice. So my recommendation is that they should find out, as we are growing, you can see we haven't got it, but we can see the areas where AI will be used. They can spell the scope of AI. We can introduce based on our context-specific issue. For now, we, as a prof was talking about the gap in skills, right? We have a huge gap in skills, and so when we do not scope who can apply AI and who cannot, then what it means is that everybody is going to get into it, and it is going to lead to this kind of wrong use and poor interpretation of information, and for that matter, compromising the safety of patients. And when it comes to GRNA, I think our duty is that yes, we've taken a social contract with society as nurses, and whilst we are safeguarding our own interests in terms of our welfare, we are also patients as well. So we can be advocates to the employer that to make work more efficient, to reduce the workload on us, and to also make reduce the cost of care in terms of hours, they can introduce more advanced AI for us. So, Madam Perpetua, there are basic things on AI that they can help us with, especially, for instance, we can start with documentation and scheduling. Anytime I take my students to the regional hospital, I quarrel with them on issues of scheduling, because they schedule to such a way that you get to the ward, and it's just somebody who has just completed, who is on duty with your student who is coming to learn from the experience. With AI, you can do a skill mix to the extent that you know at this point which category of patient should be on duty, and also in which unit based on the dependency levels of the different category of patients that are there. So we can ask advocates that this will facilitate our work and also save the banter between us, and then things will go on well. Thank you very much.
Thank you very much, Doctor. So then again, I come to you, Miss Patient Girl. Interestingly, and I want to confirm from you, are you saying that we should prepare for more climate-related health impacts? Is that the case? Are you going to experience more? Great. You are not a nurse, all right. But of course, you outline some specific rules and responsibilities of nurses in preparing for this climate change impacts. I'm just sitting here and I want to go home with at least 3 specific rules that I need to, as a nurse, develop myself in order to respond to some of these climate-related health impacts. So give us just 3 that we should just take home in terms of our preparedness towards climate-related health impacts.
Thank you very much. I thought you would address me as Madam Climate Change.
Then you are Madam Climate Change.
Okay, yeah. So as I've mentioned earlier, we are already doing so much regarding delivery of services to patients. But amid climate change, our roles will become more critical, and then our responsibilities will also expand. Regarding the roles, we should be prepared for emergencies, which means all nurses should be used to health delivery protocols and then procedure. And as I've already mentioned, some of these procedures will need to adjust them to be more climate sensitive. Okay, so the way we use to carry out certain procedures, we have to look at that again. And through in-service training and then workshops, we can see how we can make them more climate sensitive. So apart from emergency preparedness, we can also talk about health education, which is one of the roles, because we are more connected to the communities, especially community health nurses, midwives, who are living in the communities. We are also close to the patient, so we can take them through some of the basic things they can do amid climate change. When it comes to seasonality, during rainy season, what should they do? Should they expose their children to mosquitoes? During flood, how can they protect their water from it getting contaminated? The food they eat, and then all of that. We can also talk about community engagement, and I'll still refer to the midwives, the community health nurses who are living in the community with the leaders. They can talk to them and then see how they can organize community day best and then sensitize the community more on climate change. Thank you.
Great, thank you. So when I saw the narrative from one of your participants, I mean, it sounds so interesting, but I'm also asking, my observation is that the mosquitoes have become more smarter now. Could it be as a result of the climate change? Not to answer, madam. So let me take my final words from each of you. Just don't respond to that question. So final word from Dr. Gilbert, National. Let's hear your final word. Yeah.
All right, thank you very much. So I would want to say that evidence-based practice is not just an academic concept. It's not a concept that is meant for those who are teaching to be doing research on and be publishing. It is a concept that we must all be involved in. And as nurses and midwives, we are the main sources of data that is needed for health research. So we must be the drivers of that research, and we have to also be concerned about implementing evidence from research findings. Thank you.
Thank you, Professor Jelolo.
Thank you very much. So I also want to add that burnout is real. As we are intending to use AI, we can get fatigued and also get a lot of emotional exhaustion in the process. As climate change ravages, we have to work more under stressful conditions, which add to our mental health issues and also increase our burnout experiences. So truthfully, across board, whatever happens, burnout stands out tall. So we need to be careful and take good care of ourselves, prioritize our mental health in a way that can make us stay healthy and stronger for the work that we do. Thank you.
Thank you very much, Professor Yo. Dr. Margaret Kukiba.
Yeah. So my conclusion, which I never did, thank you for the opportunity, is that artificial intelligence is not a future concept. It is present reality. And for us in Ghana, the question is not whether AI will influence healthcare, but how well we will prepare to use it responsibly and efficiently. We as nurses and midwives, we are at the heart of the patient's care, and if we embrace AI, we strengthen our ability to save lives, protect communities, and advance the future of healthcare. AI does not, however, replace compassion, empathy, or human touch. It actually enhances that by freeing our hands to do that. So I will entreat all of us not to shy from it, but to embrace it. But before we can use it, it has to be context specific. Nurses in Ghana, we are not innovating. Please go forward. What can you do, just one, to contribute to developing something innovative for Ghana, nurses and midwives? Thank you very much.
Okay, great. So then let me also take a word from Miss Climate Change Patience Ga.
Okay, thank you very much, Prof. Moderator. In fact, I'm excited about all these discussions, and I'll conclude that climate change is increasing as an emergency, a health emergency. And as I've already mentioned about some of the impacts on our health and the health systems, it will be very important for us to put an eye on the vulnerable groups. Apart from that, we ourselves are service providers. We have to always place ourselves in the right position to be able to deliver care. If you are working and you are tired, at least there should be a place to rest. You should have water to hydrate, especially working in a hot climate. So what I'm trying to say is that we have to take care of ourselves well to enable us to take care of the patient. And it's also very important to be up to date with recommendations and strategies, just like she mentioned some of the benefits of using AI. We can search and see how now just not no more the general way of providing certain services or protocol, we can see a better way of delivering them. To say the time is to act now, because the Earth, as I've mentioned, is the only planet that supports life for now, and we have to protect it. Thank you.
Thank you very much. So, colleagues, Madam President has been very magnanimous enough to give us 5 minutes to allow you to ask questions. So I just take 3 questions. So, I can see a lot of, wow, great. Madam President, you know your members. Wow. So then who determines who then asks the question, because I'm overwhelmed with a number? Okay.
Select first 5.
It's difficult. Okay, so because you are wearing suits, go. I have given you a slot. Yeah. So okay, so you can quickly walk. Yeah. Yeah, because he's wearing suit, I've given him an opportunity. If you don't speed up, I will take the offer from you. Right.
Thank you, Prof. Moderator, for the opportunity. My name is Lawrence Barman, Regional Chairman for Upper West Region. I want to give a personal critique of the discussion that we have just had. Looking at the topic, let me confirm this is the topic we discussed. The topic is trends in nursing and midwifery practice, research, and education. I guess that's the discussion we had. And if that is the case, I think that there is a gap in the discussion. And I want to raise these issues. One, the composition of the panel has not given opportunity for a practical experienced person to speak for us as practitioners. And I want to make the point that maybe in support of what Dr. Gilbert said, we nurses, we trust the people who have our experience. If you look at the participants, I can tell you that more than 90% of them are from the works. They will have only academia speaking to us. Of course, research is a common area, but practically, we are going home without a message. So I think that
can you respectfully withdraw that comment, because that could be your take-home message, but it doesn't necessarily.
Okay, so maybe I am expressing my disagreement.
Yes, so can you withdraw that statement first?
And respectfully, I withdraw it.
Right.
But the point still remains that as a practitioner, I just think that somebody should have represented my opinion.
Right. So
and maybe in the words of Madam Patience, maybe we would have been having somebody to also say that maybe is the current president of GMA who is responsible for the trends we are seeing in our care. So you could
now we thank you for your submission, sir. We are grateful for your submission. It's well taken. We've taken note of your submission. Can we take a word from you?
that is just a comment. I'm here to ask a question.
We are done with you, sir. We are done with you. Can you please take your seats, sir?
Okay, thank you very much.
Right, thank you very much. So come, lady, yeah, I have seen you. But let me put on record, this is very important. Can we be together, please? Yeah.
So thank you.
Yeah, before you go on, it's important to note that most of us here are still practicing. And this is very important. Can we be together? I am an associate professor at the University of Ghana, but I work also at Christian Community Medical Center as a nurse, and I continue to work. Yesterday, I was on duty. So the fact that you don't know the background of some of us, please do not assume that because we are in academia, we are not practicing. It's very important to mention this. Again, please go ahead with your submission, sir.
Thank you. My name is Winnie Francis. I'm the Regional Secretary for Upper East. I want to talk about the evidence-based practice. I agree with my brother, Dr. Nachinap, that lack of knowledge on the aspect of those of us in the clinical site. I agree perfectly. But then the evidence-based practice, the thing is evidence-based practice, not evidence only practiced. And then elsewhere, evidence-based practice has 3 legs that it stands on. One, evidence from research. The second one is clinical expertise. The third one is patient preferences. Others add clinical guidelines to it. Now, at the diploma level, I did research. At the degree level, I did research. Fellowship membership, I did research. I'm doing fellowship, I'm doing research. Yet, we don't have the knowledge. What is the issue? And yet, there is gap when it comes to evidence-based practice. The thing is simple. At a degree level or diploma, I gave my research to someone who sat somewhere and I paid money. In fact, that is 100% plagiarism, if you agree with me, because that's not my knowledge. Now, elsewhere, to reduce this gap, elsewhere, this is what they do. They don't degree level, diploma level, you don't do research. They introduce you to the, powerful journal houses, such as PubMed. And then they teach you how to raise clinical questioning. Why is it that my patient that I passed NG2 on day 7 devolved temperature? What evidence exists? Then how do I know that others have it? Don't work on that. Then you're able to get the search terms, go to PubMed, search, you're a clinical nurse, and you get the evidence. Then you're able to apply.
So the question?
In our setting,
what's the question?
My question is, now my question is that, will he agree that the training that we give is a barrier to evidence-based practice?
Thank you very much.
Thank you.
It's well noted, sir. Now let me take, I see, yes, an officer here, please. Oh yeah, you're on the, please go ahead with your submission.
Yes, good morning.
Yeah, good morning.
Good morning. My name is Sewa from Lekma Hospital, Greater Accra region. Yes, my question is to Dr. Professor Ajilulu. Yes, so when I was single, I go to work, I can work about, like the workload of about 10 people together. Now I got married, kids are inside, and so even before I leave the house to work, I'm already burned out. I'm burned out from the house even before coming to work. So it's not only the burnout from work, but we're already burned out, and now we come to work late. We need places to leave our kids. We don't know what to do. So if it's possible, Madam President is here, if it's possible, can every facility have a nursery or a place for us to keep our children? So this workload, yes. Thank you so much.
Thank you very much for your question. Yeah, so I gave you the chance as well, and then the last person, that will be a lady here. No, gender balance, gender balance.
Okay. Right, thank you very much. Mine is just a contribution. Start with, I observed that the previous contributors, I have said this anytime I had an opportunity addressing a function or gathering, the use of our hands. I observed that the previous speakers were using the left hand to refer to revered panelists. And please, let's take note. Then the other one has to do with...
so the question...
no, it's a contribution.
Oh, it's a contribution.
Yes,
okay.
yes.
So you have...
So my contribution is the consideration about clinical faculties. All that we have discussed, it has nuances in clinical faculties. Is it not possible that probably beyond the mandate of GRNMA, serving, however, advocacy can be directed? I heard some descriptions like deliberate and intentions. And so some of the things that we really want to be done must be done intentionally and deliberately. Yes, academic faculties are there. Sometimes it is about the phobia that somebody hasn't started it. Yes, nurses and midwives can't do that. With the regulator, union, coming together with other stakeholders, what we need sometimes is not just sitting in the four corners of the classroom. For example, you are a doctor or a PhD holder in the clinical area. You do not need to be in academia to be given a professorship, award. You can't do same being at the clinical area. So let's develop areas in the clinical side such that we don't even need our nurses going back to school, vacating their posts, creating shortages where we talk about there are nurse and midwife shortages. They can be on the ward, clinical areas, guided, navigated, and the certificates are awarded accordingly. Thank you.
Thank you very much. I have already called the next person to ask a question. Can we give her the opportunity to do so?
Thank you for the opportunity. My name is Vera Asima Aka.
Let's be together, colleagues. Yeah.
I'm a perioperative nurse, and listening to the presentations, that on climate change, I can relate when it comes to what the work we do and the kind of waste we generate. So mine is a recommendation to our nurses that the things we use, we should be part of procurement and give our advice as to the kind of things that are purchased, so that when it comes to waste generation and management, we get the biodegradable. Carbon dioxide will not be emitted because we are not going to burn the waste or incinerate. So that is where I am coming from. Then with the AI, the presenter mentioned that we can use the audio to text, and when you are done with your care, your documentation is done for you. But I would also want us to do it with caution, because our accent and the AI, it's kind of give you the wrong words. You may be saying something and the AI will give you a different word. So if it generates the text, you should also make a conscious effort to read through the records before you sign, before you go. Right. So that's my submission.
Thank you very much. Thank you very much. Can I please apologize to those of you who want to ask a question, but I will not allow you to do so. Accept my apology. So on this note, colleagues, it's been a very exciting conversation. I always say that the best place to actually engage in some of this conversation is on the streets. So let's meet out there and continue the discussion. Madam Chair and Madam President, We appreciate the invitation and we thank you for this great discussion, that you created space for us to have, and I thank you for your show of partnership and again, even your comportment. Thank you very much for having us. Thank you.
Please, let's do it one more time for the panel. All right, thank you so much for sharing your thoughts, expertise, and everything with us today. And that was Professor Charles A.J. Ampon, the moderator. We also had Professor Samuel Ajololo, Dr. Gilbert Nachina, Dr. Margaret Kukeba, and Ms. Patience Kayiriga. Please, let's do it one more time for them. At this time, we are tweaking the program just a bit. In fact, we're to move into the next panel. But we have the consultant for our strategic plan with us, and because of his return ticket, we want to have the opportunity to discuss the strategic plan now. He will do a presentation, and then after the presentation, we will have your inputs, your questions, your recommendations, and then we'll end that session and move into the panel 2. So there's a lot of movement going on. I'll really appreciate if you can take your seats so that we can have the session on the GINMA strategic plan. And the consultants to do this for us is Professor Segler from the University of Ghana, and he's also from KSAM Consulting Limited, and that is the consulting firm we are using. Please, let's put our hands together for him as he comes to the podium, and he will give more details in terms of self-introduction. So please do that before you zoom into your presentation. Thank you.
Thank you, Madam. Good afternoon, everyone. So good morning. Just to correct that, I'm not yet a professor, so I'm Dr. Segler. And I'm also not with the University of Ghana, with Ghana Communication Technology University. Okay, thank you. So my special thanks to Madam President and the executives for giving us this opportunity to work on your strategic plan. And also want to appreciate the regional executives that we reached out to virtually for your input into the drafts. So I'll be doing a brief presentation on some key areas of the strategic plan. One key tenet in strategy formulation is stakeholder engagement. So it is work in progress. We are presenting some highlights to you, the critical areas, for you to also make inputs so that from this session we can finalize the plan for presentation. So once again, my name is Samuel Segler, and I'm the lead consultant with KSAM Consulting Limited, working on the strategic plan. The starting point for every strategy is the mission and vision of the organization.
because the strategy will have to derive its source from the mission and vision and also the purpose. So we took a look at your mission and vision, and then we also did some environmental scanning, a scan of your internal and external environment, some SWOT analysis and pesticide analysis to look at how things work around your organization. So some of the key strengths that we identified is that you have an established presence nationwide. When we talk about GRNME, everybody knows about you. And once your name is mentioned, we know what you stand for. You have a clear leadership and governance structure across the country. And you are strong in terms of advocacy. Nobody can take that away from you. You have a growing number of members, and the expectations and demands of union members keep increasing day by day. That would put some stress on you in terms of your ability to meet the expectations of all these members, and that is one of the weaknesses. Also, we have some professionals leaving the country seeking better opportunities, and as they leave, that will reduce your numbers. The reduction in numbers will also affect your finances. But there are many opportunities also available for global networking to influence policy or to continue to influence policy, and also to build capacity of your members. And I've enjoyed this morning session as I sat at the back listening. I was also learning a lot of things. Due to some demographic characteristics, you have a growing number of your membership being young people who may also have some expectations that if care is not taken, you may not be able to meet. And some will have different expectations at various points in time. That is one threat. You may also have to deal with regulatory changes from time to time and prevailing economic conditions. Now, after that, we also looked at the external environment. Some other factors that are very likely to affect your operations, and effects can be both positive and negative. So we look at political factors. Within the political landscape, you are well recognized by the government. You have government recognition. You have collective bargaining rights, and so you can negotiate with government. You are also able to influence national policies, and you work within a regulatory framework. So that is the political angle. Economically, your funding comes mainly from membership dues and grants for your projects. Again, prevailing economic conditions in Ghana, whether good or bad, will definitely affect your members and affect you, because you also procure things. For this conference, you have to procure services and goods. If the prices are high, you will bear the cost or the consequences. So those are some of the economic factors. Then, socially, you embark on professional development programs for members, so you have that impact on the individual members, and your actions or your operations in terms of your practice will also affect other individuals who come to you for services, and that is part of your social impact. Again, another social issue is perception. The perception that some professionals disrespect patients, they abuse them, or other things. These are social issues or perceptions that you would have to deal with from time to time. Then we talk about technology. I heard someone talking about AI. In this modern day and time, no organization can thrive without technology. And I am currently consulting for 2 big private hospitals in Ghana. And if you look at the things that they want to do using technology to render health care, you'll be amazed. I cannot give you details for ethical reasons. So technology plays a key role in your operation, and the future is technology. So it means that as we move forward into the next 5 years, we also have to look at how you can make use of technology to enhance your profession.
Environmentally, we talk about climate change, we talk about Galamsey. Take it or leave it, it affects us as individuals and also affects you as professionals in the discharge of your duties. The health issues that arise out of Galamsey will end up in your wards and you will have to be dealing with them. Then we talk about other risks. Then legally, you will have to comply with regulation and also some other factors. So that is just the external environment. Now this is where we want to spend time. After all this, the document is bulky. Some are narratives, so we'll leave those ones out. We need your input on this critical area. The strategic pillars going into the next 5 years for the association. We came up with 6 strategic pillars. The first one is effective governance and leadership. And the goal is to strengthen leadership and governance structures to effectively advocate for nurses and midwives. The second pillar is education, research, and professional development. The goal is to enhance the professional development and welfare of members through education, training, and research. The third one is welfare of members, and as a labor union, there is nothing you can do without talking about welfare of members. So welfare is a key pillar to improve the socioeconomic welfare of nurses and midwives through advocacy and support. The third one is advocacy, to influence health policies and advocate for the advancement of nursing and midwifery profession. The fifth pillar is membership growth, to increase membership of the association and enhance our bargaining strength. And the last one for now is partnerships and collaborations, to foster partnerships and collaboration with stakeholders to promote the interests of nurses and midwives. You would see that I've left some blank spaces. Out of this discussion, if there's need for an additional pillar, we would think about it and then we see how we can do that. Now we'll take them one after the other, look at what specific actions we want to see under each of these pillars. And then after that, we'll come to you and then we'll take your inputs. If you think that we need to enhance some of them, modify, change, replace, or introduce new ones, we'll take those inputs from you. So the first pillar, effective governance and leadership. Under this, we want to see the following actions. Identify members with leadership potential for coaching and grooming to enable them take up future leadership roles at all levels of the association. Identify, groom, and support deserving members to occupy strategic positions in the health sector to advance the cause of the association. Hold annual dialogue sessions with members across the various levels to seek their inputs into major decisions like what we are doing today. Organize regular trainings on leadership and the changing dynamics of unionism for executives at all levels. So that is for pillar number 1. If you have concerns, please note them. When I'm done, we'll come to you and then we'll take your inputs on that. Pillar number 2, education, research, and professional development. Establish the Labor Institutes, provide continuous professional development training programs for nurses and midwives to enhance their skills and knowledge, educate nurses and midwives to understand and apply global standards in their practice, secure and recommend continuous professional development and exchange programs for members, research into emerging trends in nursing and midwifery standards and practices and use same to influence policies, and then research into labor issues and conditions of service in other jurisdictions to help negotiate better. We move to the third pillar, which has more actions than any other pillar, welfare. Establish an insurance scheme to support the healthcare of members, lobby for improved healthcare support for members and their dependents, introduce housing schemes for members through partnership with government and other agencies, lobby for enhanced rent allowance for members, lobby for improved deprived area incentives for members, negotiate improved conditions of service for members, work with relevant stakeholders to improve the retirement scheme for members,
lobby for free tuition for all post-basic training and specialized training for nurses and midwives, work with relevant stakeholders to reduce the long waiting period for payment of benefits due members, lobby for vehicle import duty waiver for members, negotiate for book and research allowance for clinical staff, and negotiate with government to unfreeze market premium. These are the actions under the welfare pillar. We go to pillar number 4 on advocacy. Advocate for policies and laws that support the rights and interests of nurses and midwives. Advocate for mental and health well-being support, as well as structured stress management, counseling, and burnout prevention programs. Establish the GRNMA Media, that's a TV channel, to educate the public and project a positive image of the association. Hold policy dialogues with government on key issues affecting the healthcare sector in Ghana. Pillar number 6. Foster partnerships with international organizations, government agencies, and other stakeholders to promote the interests of nurses and midwives. Liaise with the Nursing and Midwifery Council to review nursing and midwifery standards in the country on a continuous basis. Work with NMC to review the nursing training curriculum. Partner with governments and other agencies to establish a medical or diagnostic center for nurses and midwives across the country. Collaborate with external partners to secure scholarship and exchange program opportunities for members. Hold biennial stakeholders forum with Ministry of Health, NMC, and facility heads to find ways to strengthen the health sector. Collaborate with international and local organizations to secure funding and support for the association's projects. Partner with other labor unions in Ghana, especially those in the health sector, to lobby for improved conditions of service. And the last one on membership growth. Embark on outreach programs to nursing and midwifery training institutions to sensitize students on the benefits of joining the association, engage new graduates and practicing professionals to promote the association's value, sponsor awards for best graduating nursing and midwifery students as a form of awareness creation, leverage social media and online platforms to communicate with potential members and showcase what the association does, offer discounts, scholarships, and other benefits to attract new members. Then we have a proposed roadmap for implementation, what should happen in the first year, second year, third year, all the way to the 5th year, and then implementation strategy. Over my 15 years of practice in this area as a consultant in strategy, we have always done strategic plans in a certain way, where you have the implementation plan specifying each action, timelines, and everything. And I've been involved in review of strategic plans for many organizations. You go back and most of the things are not done or they are not achieved. And the question is why? You realize that the rate at which things change today is faster than it used to be. So you can have a plan today hoping to start January. By January, February, things will change, which will put that action somewhere and focus on something new. So as practitioners, there's a new way and a new trend in the industry. These days, we don't do that implementation plan. We do what we call annual work plan. So you have all these actions agreed and accepted. At the beginning of every year, leadership will sit down, look at the whole framework, tease out what specific actions you can focus on within that year, allocate resources, and then you accomplish those ones under each of the pillars. The second year, you choose those that are applicable, you work on them. By so doing, you are able to work on all of them, and at any point, you can introduce new ones or replace some of them through the review, get approval, and then you do them. That has proved to be a more effective way of drawing strategic plans. So that is what we are proposing. But if the association thinks that we should still go the old way, as consultants, we will obey you, and then we'll take your instruction and work accordingly. So we'll come back to the pillars with permission from President.
one by one. We want to look at the various actions under each of the pillars. We need your input to make it better. So we would, at this point, pause and then take your inputs. We'll take them one after the other, and then when we are done, we conclude on that. Thank you very much for your attention.
So, comrades, we've heard Dr. Segler has presented what they have done as a consultant for the review of our strategic plan. You know, the old strategic plan that we had was from 2020 to 2024. And the strategic plan had 6 main thematic areas: leadership and governance, education and training, campaigns and communication, research, welfare of members, and influencing health policy. If you look at the pillars prescribed now, it syncs with the old one and introduces new things. So at this time, your input beyond what you gave us through the surveys is very important. And I'll open the floor at this time for comments, contributions, inputs, recommendations, whatever it is. Please get the microphones up so that you can line up and make your contributions or ask relevant questions.
All right, so thank you, Madam Chair, Madam President, for the opportunity. I would want to find out that I have taken a good look at the previous plan that we had that has expired. But then my main concern that I had from there, not on any of the specific ones, but looking at the new ones that you've done, is it always the case that we would have to let it elapse before we would revise it? Don't we have allowance whereby, let's say, after a year or two, we feel that, you know, the plans that we are having, we need to alter it a bit to see what we want to achieve? So is there any allowance that, you know, we could have such that, let's say, in a year or two, we'll be able to tweak it a bit to meet certain demands that are coming? And that is, you know, owing from the fact that let's look at what happened recently about our issues with the industrial actions that did occur. I'm sure that, you know, our plans, you know, did cover some few aspects. But looking at the fact that things, you know, change over the course of the period, why wouldn't it be possible, or should it not be possible that we should be able to tweak this plan in the course of the period, let's say the 4-year period? So that is what I want to know, if it's possible we can do it that way.
All right. Thank you.
Maybe you note down. Let's take a few and then you answer them.
Thank you, Madam President. So this would have come up in the PPMU presentation probably, but because we are discussing the strategic plan, looking at campaigns and partnership, we are considering the possibility of having something on green transition, where we can have something. We are already doing some campaigns with regards to climate change, and putting in certain key initiatives that could score us carbon credits, so that we would be better placed in winning grants and all these things, because we have hostels across all the 10 administrative regions. What are we doing to be climate friendly in all these things? It is the approach we give to these things that would also inform some of the policy positions we offer, so that the impact of climate change on our work conditions would also be felt. Thank you very much. Thank you very much, Madam President. My name is Michael Dwyer, Bonga Hafu. It has to do with the first pillar, and that is the leadership training. I was of the view that we could look at it from the nursing training, where we would start training the younger ones from the nursing training through the GEMTA caucus or the establishment. That will help a lot. So before they even get to the mainstream nursing practicing, they might have had the hands-on training, which will help the association. Thank you very much.
So you're saying we should incorporate this in the first pillar in terms of leadership and governance?
Exactly.
Okay.
Thank you.
IT, please put up the pillar with the strategies. Yes. Please go ahead.
Thank you, Madam President. Mine is with the second pillar. I was elated when I saw the one on the exchange program, but I want...
we are on the first pillar. Do you have any comment on this first one?
No, please.
You can sit here. As soon as we move to the second one, you come up with your contribution. Any more on the pillar one? Yes, please.
Thank you very much, Madam President. I'm Etonam Abba. Mine precedes the first pillar, has to do with the SWOT analysis that was done. I don't know if I have permission to comment on it. Okay, so I want to find out, it may be uncomfortable, but we have a trend of unions that are breaking away from the association. I feel that if that could be captured as one of our threats, so that we can design specific actions towards addressing it. Either deciding that we want to do what was done in 1960, where efforts were made to bring all together, or how we can go about it. Thank you.
Thank you.
Thank you, Madam President. I'm Musa Idrisu Anoyas.
Please speak up a bit more.
Okay, I'm Musa Idrisu Anoyas, Upper East, Assistant PRO, Regional. My issue is the pillar 1, and the last one, polling engagement with policymakers, which is very important. And if this help, it will actually help.
Media team, can you keep the slide up?
Yeah. Because why do I say so? Sometimes some decisions are always taken by leadership in governance, and it comes down, it doesn't actually favor members at the grassroots. Why do I say so? Decision will take non-deprived and then deprived districts. If as leaders in GRMA, and these questions always come as a discussion, there will be directive on what to go, where to go and where not to go. Because if I'm working at the non-deprived area, in terms of monitoring, yes, I don't have problem. But when it comes to promotions, it actually comes to affect some other in the deprived areas. So I'm very happy if this strategy is part of it, and then leadership of GRMB will be part to always take a decision on our way forward. Thank you.
Thank you. Can we have... Well, what's the name again? Alliance. You got the consultant confused. And he was whispering something to me. He doesn't know I'm also confused. So maybe you should you should summarize it and be more precise. What exactly are you talking about?
Yes. Let me go straight. There is a policy that we all know promotions to be 3 and 4. But that policy came that if you are in the deprived area, you will the promotion will come in 3 years' time from the time of your appointment.
Yeah.
And then we all know that strength. Now, the strength have changed to, if you are in the deprived area, you go for 3 years. And if you are in 2 years, okay. If you are in a non-deprived area, you go for promotion from your first appointment 5 years or 3 years, okay. So in this way, it's actually, maybe I completed school with her. He is in the deprived area. I'm also in the non-deprived area. So in 2 years' time, I'm going for promotion. And I sit there, do referral to her. Are you getting me?
Okay, so annoyance. We understand the dynamics.
Yes.
The employer has done it that way.
Yes.
To motivate.
Motivate, yes.
Our colleagues who are in the deprived areas.
Yes.
This is association's strategic plan.
Yes.
And under effective governance and leadership, these are the strategies that are being put forward. Do you have addition to this? Or a comment in strengthening these or adding on? Because what you are talking about, are you saying it links up with which point?
It links up with whole annual dialogue session with members across the various levels.
To seek their input into major decisions. Yes.
So I'm only saying that if that is the issue and they are seeking that inputs from GRMA in the governance.
This is we as association ensuring that at any point in time we dialogue with our members working at the various levels to get their inputs into decisions, and taking on their inputs as also information that empowers us to dialogue with the employer and so on and so forth. So governance here is not for the employer, it's for us.
Okay. And so if we have that dialogue with the employer, I think these inputs we can advise them. Exactly.
Thank you, Annoyance. Thank you very much. Yes.
Thank you very much. My name is Evelyn Osayamwa, Northern Region. My suggestion has to do with...
Please, let's have some order. Yes.
My suggestion has to do with the first and the second points.
Okay.
My humbly plead is that when we go through the JRNMA awards from the districts to the national, to the regional to the national, at the end of the day, these people that are being identified and are being awarded, we can see potential leadership in them. So my humbly plead is that can we make a point specifically pointing out to those people that after these awards, they are not just left to go back from where they are coming from, but the association will have to make good use of them, at least for that tenure of office, holding that position of regional bestness, national bestness, and whatever. So as part of identifying these members, let us, if we can please identify something specifically to this caliber of people because they are potential leaders.
Thank you so much for your contribution. I can see the consultant is writing, he's taking notes. Yes.
Thank you very much, Madam President. My name is Dora Kwabwa. Please, I would like to ask if we can incorporate the training of specialized groups in the Pillar 1, if we can pay some attention to the training of specialized groups we have in our association.
You are all members of the association, so when we talk about identifying members with leadership potential, it's everybody. We don't leave anybody out. We can't segregate specialized societies from GIMA branches, regional districts, so on and so forth. It's one body, it's one family. We keep talking about this. Let's stay united, let's stand together. Don't see yourself as on one side and somebody on the other side. We are one big family, okay? So when we are identifying
a specific needs,
when we identify potential leaders, we will never close our eyes to specialized societies. We will take everybody into consideration.
Thank you very much.
Thank you very much, Madam President. I'm Isaac Boatin, be a second vice. My concern is about the first slide, which is the SWOT or something.
The SWOT analysis?
Yes.
Okay.
I'm more focused on the threats. And I think GRMA is now losing a lot of members due to the breakaways, as my brother have already suggested. So we considering the threat as a pillar, I think it should be something that we should really look at. And I'm saying this because I remember 3 years ago when I was the district chair, I oriented 42 newly posted nurses. They all selected GRNMA, and the other unions took them all and gave me 2. And that's one painful thing that I will never forget. So, how do we handle these threats? My recommendation is that, though we see them as opponents, but we should find a way to bring them on board. We are not entertaining them, though. We all know the 2 major political parties in Ghana, NPP and DC. During their conferences like this, they invite them to come and give their solidarity message. And in that case, you are weakening them. Assuming the UP people came here to give a solidarity message, when we bring them on board during our negotiations and stuff, that will not take away the power from us. But I'm looking at the losses that we always get. Example, this negotiation that we just did, there are a lot of things that nurses and midwives would have benefited, but because of them, we lost most of it. And even they turned the society against us. So, please, I'm just pleading, if we can reconsider and then bring them on board so that they will feel that they are part of us, though we are in different unions, so that we can fight the same cause for the benefit of
Thank you for your contribution. We'll look at strategies around that. Thank you. Yes.
All right. Thank you, Madam President. My name is Abutu Daniel, Volta Region. Please, what I'm coming to talk about, it's about the office space for districts, our various districts. In the previous strategic plan, it is clearly stated that the association will work on the office spaces for every district. And I know Madam President said some years in one of our meetings that if any district is having an office, they will try to furnish the office for us. But in our cases, most of our districts, the rent that they take for the office space is monthly, and we are being paid quarterly, and even that quarter we can use part of that money to pay for rent for our office space. And during the review, I want to add that if the association or leadership can review this strategic plan in the old strategic plan to work on or find a better way to get office space for all the districts. Thank you.
Thank you. So we'll take the last 2 on this pillar and move on.
Thank you, Madam President. My name is Bismarck Haduvosa, Volta Region. Please, about let me just add to what my brother said about UPNMG thing.
Can we move on?
Okay.
Please, let's move on.
I'm guided. Thank you very much. The SWOT analysis. One of the threats that Etonam almost touched on is the penetration of UPNMG into our nursing schools. They go as far as sponsoring or partnering with
And please, moving forward, don't mention any specific splinter union or association.
Okay,
just keep it general.
I'm guided.
We are live, so just keep it general.
I'm guided. So they go as far as sponsoring some of these programs with television and stuff. And now one thing I've seen of late is that once we have GIMTA, they've associated with GRNMA, and another name is put on a fraction of them, which is, so if we can identify that as one of our traits and then work towards that, it will help us. Secondly, on the strategic actions, I want to plead if we can add financial accountability. We should find a way of being accountable to members directly once in a while. Like we had the treasurer presenting to us in a nice digital environment. You have met us severally online. So if you can do that once in a while, generally we render account. That amount to good, effective governance and leadership. And also finally, Madam President, when you go to the public health outfits, where we are losing most of our members to other unions is at the directorates. And what I have observed is that most of these other guys from the other groups are public health nurses, district public health nurses, and they tend to control them using I'll give you leave, I'll give you permission to travel. So if we can do something about that in under this pillar, I think it will also help us.
Okay, so just to respond to the first and second one, GIMTA is synonymous with nursing and midwifery in Ghana. They've been in existence since, I think, the 70s or so. Even when I went through nursing and midwifery, they were already in existence. So there are leaders at the time when there was only one association, which was Ghana Registered Nurses Association, help in the formation of a trainee association that will also represent the student body. So it is never the case that GIMTA is for just GINMA, and now for some reason some splinter union is trying to institute a student body to serve their purpose. It is wrong. What they are doing is wrong. Yeah. And I wish they will appreciate that their actions or inactions affect the profession directly. And if they are true professionals who value the nursing and midwifery professions in Ghana, they won't be doing what it is that they are doing. So, unfortunately, that is the path they have taken. We will have to find ways, like you're saying, to mitigate the impact it has on the profession, not necessarily just GRNMA. Now, the second part was to do with, you mentioned the second one was to do with financial accountability. Within the Constitution, the National Treasurer is mandated to give reports at Delegates Conference. Within the quarterly National Council meetings, the Finance Committee gives its report, and the Treasurer is in the Finance Committee. The first Vice President is in the Finance Committee. So every quarter they present those reports, and council members are mandated to move into their regional councils, present those reports. District executives are to move to have their general assemblies within their districts and give information to the members. We cannot create a different system where we tax the National Treasurer to be on virtual meetings and then be talking about the finances of the association. We have the structures and we have the systems that have worked over the years. I'll plead with you that we let it work.
Thank you.
And you are empowered as a district executive, as a regional executive, to do the needful. So let's try to strengthen those structures so that members, ordinary members, can get the information they need. Thank you very much. The third one, he has taken notes.
Yes, and also, finally, then I take my seat.
I thought you were done.
Yes, but because you spoke. Madam President, the one that we are, the expired action plan.
Okay.
I think it's not enough just discarding it. We need to evaluate and see what we have been able to do.
We have evaluated it already. We have done that at the level of National Council. It's not everything that will come through delegates conference.
We birth the action plan.
You did what?
We birth it. We come together to adopt it. We accept it. It's our document.
Yes.
So when we finish, I think it's just in the interest of fairness that as conference like this, we should transparency. We should know what we've been able to achieve.
My colleague, no, listen. You can't come to conference and come and score anything. The strategic plan, everybody has a copy. It is also on the Infonet. It is up to you. Whatever we have done over the years, if you take each pillar and look at the specific strategies, you will know what it is we have done and what we have not done. As part of our good governance, we evaluate ourselves on a yearly basis to see what have we done. That's why we have the PPME committee. They have done it. They have done it already, and it has guided us.
I really want
but we can't come to conference to come and do evaluation and score here and see how it impacts the review. Please, I beg you.
I know you've done. I really wanted to give you 90%, but thank you very much.
Thank you very much for your contribution. So we'll have the last one on this pillar and move on.
Thank you very much, Madam President. My name is David Sam, a delegate from Greater Accra region. I first want to touch on the third point under the strategic actions. If you look at what we currently achieved within the past month about putting the next souvenir as a poll on the Infonet and getting members to share their view, it's really incited some form of belongingness among the rank and file of all members. And I think it should be something that contributes much to this point. If we are to just hold annual dialogue sessions, it will limit the member inputs that will be made into major decisions. But if we make it that as and when there is something like maybe strike, we saw certain people maybe at the university levels when they were declaring their strike, quickly getting to all branches to vote on the decision whether to keep it going or to suspend it within a way. I think the Infonet can also be used in such situations, and as and when there is a need, then we get all members to make their inputs. And
thank you very much.
I also wish to end with this one. When it comes to the leadership potential of coaching others, I want to touch on the gender issue too. Among the nurse educators group, we can get key focal people who are real GRNMA enthusiasts to serve as guides or coaches to the gender executives, so that when you go to each school and their teachers are really with them, guiding them on how to progress from the gender level to GRNMA level, I think the impact will be more than what we are seeing.
Thank you very much. I said he was the last one. I'm not going to take any more contributions on this pillar. Thank you very much for all your contributions, and I think we can move on to the next one. A question for you.
Yes. There was a question on the review. The review can be done anytime. The normal practice is that we do mid-term review. Within the third year, you can do a review. But the approach we are proposing would even allow you to do annual review. When you are drawing your annual work plan, you do a review and see if there's need to change anything, then you can do that. Thank you. The rest will look at them and see how best we can incorporate them. Thank you.
All right, so let's move on to the next pillar, please. IT. Media team. Next. It's on, okay. So education, research, and professional development. And these are the strategic actions. Any inputs, questions, or recommendations? Yes.
President, I'm Abiyonatu from Western Region. So mine is in line with the fourth point, that's secure and recommend continuous professional development and exchange programs for members. So mine is on the exchange programs. I want to ask if the exchange program is going to be within the country or is going to be outside. But I also recommend that we should even do inter-regional exchange program, because there are some practices that are maybe ongoing in Kolebu that are different from CAT. And then even within the district, you will find certain nurses who don't even know how to use operate the oxygen cylinders. And it's a practical example that is happening. So in carrying out that aspect of the strategic plan, please plead that you consider those areas for me. Thank you very much.
Okay, so the suggestion she's making is look at interregional, inter-district, and even global. So it will all be considered. Thank you. Yes.
All right. Thank you, Madam President. My name is Ayinga Anafo Matthias from Saviligu District. Mine has to do with the transition of our certificate nurses into professionals. In one of our district engagements, a lot of people had the concerns that we are having difficulty with our COS and then professional development allowance because of that gap between the professional and then the auxiliary staff. So yesterday, in the course of the presentation, the keynote speaker also mentioned that there is the need for us to have a strategic plan in transitioning them from the certificate to the professional level. I want to find out, I remember also that in who you specifically mentioned it, but this time I didn't hear anything about it. And some are asking that what plan do we have in upgrading those who are already in the system and doing away with the current one? Thank you.
So it is not our responsibility. It's not our responsibility to upgrade anybody. It is the responsibility of the employer. And the employer will also upgrade based on their needs. What we have continuously advocated for is scrapping of the certificate program or the auxiliary programs. For us as a country to focus on BSc training of our nurses, to make it easier for them to even do specialty programs. The diploma can be allowed to run for a bit of time before we scrap it off totally. Now, if we change these programs, what it means is that we will have those who are practicing on the old certificates. It becomes a national policy to say that if you hold this, you go through this program to upgrade yourself. So these are discussions that are ongoing. The last time the Ministry of Health held a technical meeting on this, we made several suggestions and several inputs. So it's a process that is supposed to start. Our concern now is to put forward the justification for the ministry to start now. And yesterday, I think I said it in my speech, that it's long overdue. We've identified about 40 colleges that can run the BSc program. Let's do it. What are you waiting for? Let's start it. And then we can find a way of transitioning the auxiliary nurses to come at par with their colleagues within the system. Yes, the last two.
Thank you, Madam President.
Last three.
My name is Wisdom Wache, Organizing Secretary for Critical Care. So my question and concern with regards to this particular pillar. Yesterday, the health minister was here, and he made mention of introduction of some programs, some new, some existing. And he explained that because of some demands and shortages, so they want to run some of these specialty programs within a year and even add some more schools to it. My concern here is to know the position of GRNME on this, whether looking at this pillar, were we consulted? Do we have a say in this? And how does this affect us? Because we've always had shortage of doctors, but the training of doctors have not been reduced from their 6 years to 3 years, so that they can have doctors come in quickly. But I'm a product of such school, and I know that even the 2 years we run, by the time we are ending the 2 years, you know that there are a lot of, the 2 years is not even enough. But now, these programs are going to be run in just a year, including theoretical aspects, the practical and everything. So I want to know their position. I'm sure if it's about the doctors, GMA will definitely have something to say. So what are we saying about this?
Don't leave. Don't leave. The associate program run at the college. The associate program, it's how many years? 1 year. And it covers which specialties? Almost all. So the associate program within the college is 1 year. Obviously. And it covers, it covers all the programs. The idea, this idea was first put across by the former minister, Honorable Kwekwajiman Menu, to move the associate program as it is, because the college, they don't have the capacity to train a whole lot of them. So let the NMTCs, it's the same idea that is being carried by the minister. Our position will be that it is not treated as a separate program or as a specialty program. They have to work hand in hand with the Ghana College of Nurses and Midwives to ensure that if it is the, I'll give you opportunity, if it is the associate program that we are trying to expand and therefore instituting maybe centers in these other NMTCs, then all well and good, because just like you described, we cannot have a specialty program that is downgraded to a 1 year program. Where are you going to take those individuals? But like I said, the associate program has been running for years. And if it is the idea to expand it to these NMTCs, I'm yet to hear from, we are yet to sit. We haven't been invited for any meeting. Okay. So I cannot tell you our position. Even at NEC level, we haven't discussed it, neither at council level. So we will need to finish this conference, go back, really understand the model that the Ministry of Health wants to carry across, and then we'll engage and make our inputs.
Madam President, respectfully, kindly endure me a little bit. The minister was clear, these programs will start next year, January, and that they are BSc programs as they are already running in, yes, he mentioned it, that they were going to be not associates as you are trying to explain. So I was just thinking, so if you have not been consulted as at now and the programs will start in January, then I don't know.
Yes, you are telling me, and I'm also telling you I don't know, because we all heard it for the first time yesterday. So what are you talking about? We all heard it in this hall, and you want the association to give you its position. We all don't understand it. Courage has been raising his hand. Maybe he has more information. If you have more information and you want to share, please take the mic and share it. But we will go back, delve into it. Next year, we will see how it goes.
Thank you, Madam President. I just want to say, hello. I just want to say,
please, let's have some quiet and listen. Yes.
What is currently, we already have some universities that are running BSc programs, and towards your exit, you have a specialized area in pediatrics as a BSc program. So sending the associate programs into the universities so that by the time somebody finishes a BSc program, we are not only training BSc like general nurses, but those special areas it's actually the entire point. And just as President said, it's the association will also make efforts to engage, to make sure that we stick with, certainly even G-Tech and the rest, nobody can train a degree program in a year in this country. It's impossible, and that's a fact, because the laws do not allow it. Thank you.
Thank you very much. But you also are well aware that although these universities run the BSc so that at the tail end you pick a specialty, nothing much is done with those specialties. It's more like you just select it and then you complete your BSc. But you don't get the practical sense of the experience to actually say that you have a specialty in this area. So if the idea is to build it in such a way that you actually can be called a specialist in that field, all well and good. But like I said, as I sit here, we've not attended any meeting on same, and we'll go back to understand better what the Ministry of Health wants to do. Yes.
Thank you very much, Madam President. I'm Awal, Acting Chair, Tamil Metro, Northern Region. Under Pillar 2, I humbly suggest if Council could incorporate the sponsorship package for nurses and midwives into other non-nursing and midwifery courses, like law, maybe in labor relations, so that the chunk of money we spend on hiring all those professionals, at least it will go in a long way to curtail the amount of expenses we spend on those things. So thank you.
You know the total, you know the total membership. You know the total membership. And at any point in time, in any academic year, the number of people who aspire to go and do programs, that one, it is the employer's responsibility. We cannot sponsor people to go in for those programs. It's an individual choice to pursue a certain line of profession. Please, I'll give you the floor again. What I'm saying is that it is your individual ambition as to where the path you want to take in your career progression. As an association, although our core mandate is welfare, it is not about sponsoring. We can advocate for the employer to sponsor. Because even at this time, we know there are certain programs that you may want to go and do. You put it in and the employer will say, we don't need this kind of profession here at this time, and all those excuses. So we can advocate better to get the employer to appreciate the need for some of these programs, and then get you sponsored to pursue those programs. But the association and its resources at this time cannot support supporting members to pursue law, to pursue journalism, or to pursue other programs that they want to do. Yes.
All right, thank you. My name is Ideas Coleman Adato, a delegate from Greater Accra, the mother region of GRNM. Thank you. Yes, so my contribution is to the Pillar 2, the Objective 1 under Pillar 2, establish the GRNM Labour Institute. So my opinion is that before we get to the Labour Institute, if we can start with Labour Decks at every region, so that the decks will be responsible for industrial or labor issues in the regions. I say so because we have colleagues who have issues with, controller deductions, and they will have to go through the district, through the region to national to get resolutions. But if you have these corresponding officers within the various regions, they will be in charge of resolution of these issues. Apart from that, too, we have diaspora arm of the association, but we don't have diaspora decks. So when they have issues, they have to call on national leadership to resolve it for them. I believe it's time that we have a desk dedicated for the diaspora people. Similarly, the Quayside people too as well. their contributions. Some of them want to remain members, they want to contribute to the nurses fund, they want to feel belonged, but we don't have that coordinations. So my thinking is that we can have these decks responsible for these institutions within the framework before we move to establishing the bigger institutes.
All right, thank you for your...
I'm from Greater Accra, yes.
GRMA is Greater Accra, and Greater Accra is GRMA. Okay, so Dr. Segla, we can move to the next one, right? Okay. Welfare of members, any inputs on this? We should not.
Good afternoon, Madam President. I don't know, but I think that when it comes to welfare, we should add social support, because some people are giving the loans and they don't even know what to do with them. They ask you, you ask them, are you going to do with the loan? And they say, oh, GB. And then, so I think that there should be education from time to time on financial prudence, and then also I think there should be sessions on and counseling or education on family life, work relationship, and conflict management at the various districts. Just like the education, we had Zoom on several topics. I think that when it comes to welfare of members, we should add social support so that people will be educated on how to handle finances and how to handle working relationship, and then how to manage addictions and other family issues. That's what I think. Thank you.
Thank you, thank you, thank you. Why will you apply for loan when you don't know what you are going to use the money for? Hey. Then we need serious financial education of our members. We've been doing it, but I think it hasn't gone down well. Well noted. Well noted. You have the floor.
Yeah, Madam President. Thank you so much. My name is Richard Apao, the assistant PRO from...
Please, let's have some quiet.
I know the association is making a lot of effort to establish hospital in the future. Yesterday, the minister responsible for health made a proposal that there are some Agenda 111 hospitals that they want to go into PPP. So I want to propose, instead of us giving the health funds to individuals, if we can divert those money into those hospitals, and then the hospital becomes fully functional, then those monies that will be given to individuals to take care of their health, they will rather be taken care of at our own hospital, so that at the end of the day, the association will save some money than giving the money to individuals. That is in my opinion. So number two, in terms of welfare,
please, our comrade has the floor. You've spent like 2 minutes already. You have 1 minute more.
Thank you, Madam President, for the opportunity once again. In terms of welfare, I want to also propose that the souvenirs, I know we are not there yet, but we should do it every other year. Like, if let's say we do it this year,
Next year we will not do the souvenir again. We will either keep that money and then push it into other avenue that will bring money to the association than every year souvenir. That is my opinion.
Thank you very much. Thank you very much. Thank you very. That's his suggestion. It doesn't mean we should work with it. The second one, I agree with him totally. I even captured it as part of my speech yesterday and requested that all regions support because it is coming up as a resolution from some of our regions. On the first part, our members need the support. We cannot cut it out at this time. I appreciate the minister's suggestion. We'll capture it as one of the resolutions and then we vote on it here before we even leave. If it's possible for us to go into it, why not? Because we are told others have already even taken up one or two of these facilities. So we'll see how it goes. We need to even engage to better understand how will you term it? The terms of it before we can take a decision. Yes.
Thank you very much, Madam President. I am Raymond Yabua from Western Region. My point goes with the point 3.
This line is getting longer. Philemon was the last person. Now, you are now the last person. Nobody should join the line again.
Thank you, Madam President. My points have to do with point 3.
Okay, please join. Just a minute. Please join. You are the last one. Yes.
Yes, my issue have to do with point 3. Introducing housing scheme for members through partnership with government and other agencies. I would humbly suggest that we concentrate on district level accommodations. When we look at our district, mostly the rural facilities of the rural district, you will realize that most districts lack accommodation for the nurses. And when you look at the computations at some districts, you could see how much nurses are paying for rent at the district level. And it's not everybody who want to maybe build at a certain district, but all of us want accommodation at the time that we are working at the districts. So if we could get something like accommodation scheme or housing flat like we have for the nurses, SNIT flat at each district, so that could also serve as a source of income for the association. So we can maybe start with 20 unit single rooms or whatever for each district. And when we do that, we'll be able to not only provide accommodation for our members, but rake in revenue for the association. Thank you.
Thank you, Madam President. My name is Bismarck Advosa. Madam President, on this very pillar, to improve the socio-economic welfare of nurses and midwives through advocacy and support, and I want to plead that we, going forward, I heard a politician mention that even markets that will be constructing now will have daycare facilities for market women. Teachers or schools will have this, to come with bungalow and this, but hospitals always come alone, not even with bungalows. So I want to plead, since we are female-dominated profession, and you are president, a woman, we should push, lobby, and advocate for our members that henceforth, starting from the Agenda 111 facilities and the CHIP compound, if they can add at least a crèche to it, a daycare to it for our colleague females with babies, so that they can put their babies there, break time, they come and breastfeed and go. Thank you very much.
Thank you. Next person, please.
Thank you so much, Madam Chair, for this opportunity. My name is Abudu Atika. I am a midwife from Northern Region. So I want to talk about the health fund. I am a beneficiary of the health fund. I have gone through breast cancer treatment, and of course, which is not easy. I am here to plead with you, if you can work with Sweden, Ghana, just like the teachers have, at least it will release the burden. Yes, you give us check and then it helps. But at the end of the day, I have met nurses or midwives who have been diagnosed of breast cancer and didn't even want to come forward to ask for help from the association because of stigma. And so if you're able to work with Sweden, Ghana, such people or nurses can just visit the hospital without anybody knowing whether they have cancer or not. And this is what I have to say. Thank you.
Thank you.
Thank you, Madam President. I'm Faili Monedu-Brempong from Ashanti region. Mine also revolves around health and housing scheme. Cancers are increasing, and for what she said, now Sweden Ghana is owned by NAT. They have bought it because they realized the money that they were giving to them. Madam President, undoubtedly, as she said, members are benefiting from the health fund. And my area, we have nurses whose kids are having cancers. And usually, they know me at CAT, so they will approach you. My child, can you help me with the health fund? I've heard there's health fund. So I am pleading, if we could extend our health care to at least one child with a chronic condition for our members. Though currently the benefit goes to the member, but if we could at least extend to one child with a chronic condition. Secondly, on health, we have members having chronic conditions, still citing cancer as an example. Can we say allocate 2% of the 10% for the health fund for these chronic conditions, so that those who need permanent treatment and support, we could use that 2% to support them. Then the last one on the accommodation, I know with the district assemblies, they get support and they use it for chips. After the chips, there are no accommodation attached to it. And I know, Madam President, from where you sit, you can influence policy that those monies that they are using to establish a lot of chips around, they should channel some to build accommodation for those chief compounds that they have already established, and there are no accommodation for nurses and midwives to occupy. Thank you.
Thank you, Philemon. But let me respond to the first one on the health fund. The health fund as it stands now can only support members, because just like you said, those with chronic conditions, sometimes we cannot just close our eyes when we know this person is on dialysis. We've given some money already. The person still needs support. We still give. So we cannot add dependents. If you look at the collective agreement we've had with government since 2016, it is clearly stated there that the employer is to take care of us up to 4 dependents. So let us collectively push for this at our health facilities. Let the management understand their responsibility. We cannot take on all the burden that the employer is responsible for. As a union, we cannot. And it's also important that as workers, we also look at other existing private insurance schemes that we can contribute to, so that in such situations, they can assist your health and that of your beneficiary. Because the health fund we are running, nobody pays premium. Nobody pays any money. It is the same dues that we've allocated a portion to support members. So we cannot extend it to your dependents. The resources cannot support it. As for the second one, I think we can look further into it and see what can be done in terms of incorporating it. Yes.
All right, thank you very much. I'm Ashley Ni Aite.
from Upper East Region, Busan of Municipal Chair. So my Philemon asked part of my question, in which you've answered part of it. But with regards to the welfare package, the first point, I would suggest that since you are going for an insurance package for members, then with the insurance package, can we consider the dependents, not from the health care model?
Can you please project that one? I didn't see how the insurance package is couched.
Insurance
Which
scheme
one?
to support members. Point one, to establish an insurance scheme to support the health care of members. So since it's an insurance scheme, we are looking at establishing, can we consider the dependents of this as part of it? And also, I think when I went through the welfare for members, I didn't see anything with regards to looking at how we could manage the mental health of our staffs. Even this morning, we've learned about burnout and mental health. Could we look at how we could see ways by which, as an association, we could look at ways by which we can help our members out of their mental health crisis, especially with burnout? Thank you.
Thank you. We are already doing some work in terms of mental health issues in relation to addiction, substance addiction, and we have done it for a number of our members, but not necessarily burnout. Now, with regards to the first strategy, you can realize that it's a long term, and it will also require that even when we put in the systems, it will require a member paying premium. It is not going to be from the dues. It will require members paying premium, and premium where you take the decision that, okay, I want to pay the premium that is for myself alone, or pay the premium that allows me 1 dependent, 2 dependents, 3 or 4. Then it can help us, but it's a lot of work. It's a lot of work. Even at the beginning of this year, we tasked the Socio-Economic Committee to look at it, how feasible it was to establish such a scheme. And we realized it was capital intensive, it also required serious expertise, and we let it be. Now that it is here, and if we adopt it, it will mean we start work to see how we can build it. It will not happen in a year, it may not happen in 2 years, but we can start it and see how your payment of premiums can allow the scheme to run effectively.
Okay. Thank you, Madam President, for the opportunity. My name is Lukman Bamengzut, a delegate from the Western region. There are a lot of concerns raised. There are a lot of concerns raised, but mine has to touch with the land sales that the association is doing at the various regions. I just want to put this thing across. Are we, as an association, considering in the future having our own land scheme, of which is owned by the association, of which surveyors and other people will be employed, so that the sales of the land will be in the association without engaging a third party, which is actually causing a lot of havoc for us? If we open the floor for members to call in to talk about the land sales, we can hear a lot of, grievances and others. So, Madam, this is what I want to ask. Is there a way or a possibility that the association will go to the various places that the land is and get it, acquired, or acquire that land, so that we can be able to buy it as a member or members from the association itself, not from a third party? Whereas the process will delay. Looking at our brand and the way that we are, I know the agencies involved in registering and other things will be able to help us so that we can do it smoothly without engaging any third party. Thank you, Madam President.
It's a suggestion, but our core business is not lands, and that is why we don't want to venture. And if you have lands to sell and you are a vendor, we only introduce our members to you. you sell it to them, they pay you, and then you handle the land documentation and those things. We know there are some issues with the Upper West lands, and then that's the only one I know. I'm not too sure there are any issues in any of the other regions, because the vendors, there's no problem. They sell the land to you, they prepare the documentation, they give it to you, and that is it. It shouldn't be a problem. We cannot use association dues, go looking for lands, go and buy it, pay for it, and now come and sell it to members. We cannot do that. We don't want to do that. It is not part of our strategy. But we use our structures to help facilitate, so that if you need a land, you get it. And there are a number of people here, I believe, who have gotten lands from their various regions. Every region has some land scheme in place, and it is benefiting members. As far as I'm concerned, there are no issues, so it can go on. We will see how we can help in the case of Upper West, the issues that have come up, for it to be resolved. But we cannot, because what you are describing will mean we go and buy and come and sell the lands to members. Land and its issues are issues that we don't want to bother ourselves with, because we don't have the technical know-how. We cannot go and take consultants in this and come and pay them huge sums of money. And there are also companies out there who sell lands, genuine lands, such that if you need land, it shouldn't be a problem. In some communities, the chiefs hold the land, and if you are able to approach them as even an individual, they are able to sell some to you. So thank you for your suggestion, but that's the response I can give you at this time. Okay, thank you so much.
Thank you, Madam President, for the opportunity. My name is Regina Kweku, a delegate from the Western region. To add to what my brother just said, in that same vein that he has supported other regions to acquire lands from private individuals, we in the Western region, we have same. But our issue is we are having issue with the people selling the lands to us. We've paid monies over 2 years, and we are still, we don't know where.
You've not seen your land.
We've not seen the land.
You've not seen the documentation.
It's a big issue in the Western region. So if you could consider that for us.
Okay. Is there any other region with similar issues? Because now it's Upper West and the Western region. Okay. All right, we've heard you.
Okay, now to my substantive issue. Mine is a recommendation. All the discussion going on here, it's about our welfare, getting insurance scheme, accommodation, getting scheme for our dependents. So I want to indulge the leadership. If these new strategic plans, the Pillar 3, if all of them is taken care of, then I think most of our welfare issues with regards to these areas will be solved. Thank you.
Thank you so much. And that was the last person on this pillar. We move on to the fourth one. Advocacy. Do you have any inputs on advocacy or any question? I think advocacy is clear to delegates present. One, okay, you have the floor.
Yeah, Madam President, thank you so much. I saw establishment of a GRNM media and then a television too. So I just want to make a proposal to you that if it will be good, we should extend the media committee's activity to the various regions so that the regions can also showcase whatever they are doing at their various regions for us to
join together with the national so that we can. Hey, bro, for no cross now. Yeah, so that we match the regions together with the national activities. Yeah. Okay. To make the regions more.
I think I get you.
Thank you.
Some of the regions have instituted their own media teams, and they are doing it perfectly. One thing you must know is that the media team we have at the headquarters, they are nurses and midwives.
Sure.
They have their regular work that they are doing.
Sure.
If we are going to say they should move around every region and be doing the region's activities covering, then they won't do any work. The employer will dismiss all of them.
Madam, that's why I'm advocating that we should establish them in the various regions. I'm not saying the national media teams going around capturing.
Oh, you mean establishing say in the regions?
Various regions. Actually, you can attest to the fact that the media, the Ghana Next TV actually started from Volta. But because lack of resources, we are unable to push it more. So if we establish them in
I disagree with you.
No, Madam President. It actually started from Volta. They can even communicate here can attest. It was established by Honorable the veterans Isabel. Yes.
In which year?
Oh, long time before before 2019. Before 2019.
All right. I think you made your point. Your point is that we should help in the establishment of media teams in the regions.
Various regions.
Thank you.
Thank you.
He was the last person. Where did the last two come from? No, he's the last.
Okay.
Yes, please go ahead.
Thank you, Madam President. My name is Bawa Yahya from Western Region. I'm representing Gapore Hospital, Takrady. Yes, actually, we are now joining the association. Some of us have not received the allowance. I don't know what the union is doing to help.
Which allowance?
Service allowance. Rotation nurses, yes.
Oh, you
yes,
mean
please.
the interns? Okay.
Yes, please. Yes, so they are asking, working close with them, we fill their plea. Thank you.
So you are registering them on the Infonet and you are having challenges?
Challenges, yes, please.
When we go on break, please come and see me. I'll assign somebody to
All right.
help you with that. Thank you very much.
Thank you, Madam President.
Good afternoon, Madam President. Please, about the advocacy, you realize that Ghana Medical Association, the doctors, when they finish their housemanship or their service, you realize that they go to do their specialization without paying. Government take responsibility of their fees. It's for free. So I would like if the association can advocate that if we nurses too, we are going to Ghana College of Nurses to do our specialization, if the government can take care of our fees for us. Thank you.
Thank you. It's been on the table for a very long time. We are still advocating. So we'll see how it goes. Yes.
Thank you very much, Madam President. I'm Etonam Abba, the ARS for Volta region. Under advocacy, I want to add, if we could add that we would advocate for the full establishment of a directorate, nursing directorate at the Ministry of Health, and also some of the agencies. Then to add that if you look at some other compatriots in labor front, their general secretaries are detached from work, their professional work, so that they are full-time administrative officers for the association. I want to put it across if we could consider it such that we are able to have that effectiveness improved in our services. Thank you.
Okay, so from the last one, that structure is different from our structure. Their structure the structure they run is different from ours. They have a general secretary in charge of everything. He's the CEO of the organization. And then they have a ceremonial chairman. Our own is different. We have a president who is the executive president of the association, and we have a general secretary and other executives. So if it is about detaching the work of officers from the regular public service work they are doing to focus on the union, we have to be strategic and take a decision and know that, okay, these are the portfolios. If you cover or you take up these portfolios, then you, the employer can allow you to step aside and focus on the union work on secondment. Some organizations, not necessarily in Ghana, have that. If you go to South Africa, the policy is such that in the nursing union, if you are up to 40,000, the government is willing to give you 5 slots. 5 slots in the sense that those 5 executives can do their work, finish their tenure, and then within that time, the government still recognizes them as their employees, promotions and everything, you get it. When you finish your tenure, you report back, and then where the level where they are supposed to put you, they put you. We don't have it. And if the thinking is, because the work we are doing is supposed to be on part-time basis, but it's more than full-time that we are doing. So it's not just about the office of the General Secretary. I'm drawing your mind to the fact that the President, the General Secretary, other executives who sit there, if that is the thinking, then we will have to look at it holistically and see how we dialogue with the employer on same. But one thing I know for sure is that there are times that executives are also interested in their professional career, such that they also don't want to leave that path and say they are doing their union work full-time. And so over the period, we have managed it. You manage it according to how you can manage it, do the union work and still do your work. So we will see how the conversation goes in the days that we are here, and going forward, how we can look at it. If it can be captured within the governance, we need more deliberation on it. We cannot just take a decision outright. We move on to the next pillar, the 5th pillar. Number 5 is on what? Membership growth. Membership growth. Any input, any comments on this? The same people coming to the mic continuously.
Madam President, we want the association to grow.
And I want to see more women come forward and speak. These issues that we are talking about, Adato, don't come back. Atonam, go and sit down. You've spoken enough.
Madam President, do I have the floor? Respectfully.
1 minute.
I'll do it 30 seconds.
Yes.
Madam President, thank you very much. As part of the membership drive, I think the award scheme for the best performed graduate from NTC, if we can.
I offered him a seat and he chose to stand. He says he's a teacher, he doesn't mind standing, so please continue.
Thank you very much. I was talking about the action that, please can you project it, about the award scheme, if we can push it down to the training colleges as well.
We can push it to where?
The training colleges. Okay, it's captured. And then also the Ghana College. I think that's where my mind is going. The Ghana
I'm
College.
not getting your point. What are you saying?
What I'm saying is that the award scheme being targeted at the NTCs, we can move that to the residencies, the specialty programs as well, because they are also students anyway. So when we do that, so that is the specialty sickness. so that we can extend it to that side also. It bring them on board. And also to add that, Madam President, the membership growth during be a way out that during national service we can capture some of them into.
All right, we'll think through it and see. Thank you.
Thank you very much, Madam President, for your generosity. I remain autonomous about the ARS for the Great Volta region. So I'll tie in from the award scheme side. I want to propose that on the issue of membership drive, if we could extend our, I know we just started recently, but if we could extend our best, regional best administrative region, okay, the best administrative region award, and also have the best administrative district, so that one of the key KPIs at that area would be the issue of membership drive, so that it really helps with the membership drive. Number two, on membership drive, GRNMA is both a labor union and a professional body. I think that some other professional bodies elsewhere or professional associations, they have that capacity of running programs and they administer certificates that are recognized even worldwide. If we cannot go worldwide, we could start nationally. For example, the American Heart Association is a professional association. They do these BLS and ACLS trainings, certify you, and it carries weight. So that if we could take up such a thing, probably tax our specialized societies, through them we undertake things like that, then the person knows that being in the association, there are such certificates that I could get that can be recognized for me to use in practice and even file for some advanced levels, if we could consider that. Thank you.
Thank you. The line is getting too long. We need to finish this, finish this session. I appreciate, you are the last person, right? Okay, 1 minute, please.
From the Eastern region. Personally, I would like to second the point raised by Honorable Bismarck. We have rotation nurses and midwives coming on board asking us, how can I belong to the association? So if our Infonet system could, in a way, adopt some of these rotation nurses and midwives in the interim before they get their employment, it will be a great benefit to us. Secondly, those who are newly recruited, that is the graduate unemployed nurses and midwives. First of all, I would like to thank you. Somewhere 2019, 2020, you gave us the opportunity to sit with Stanbic Bank, and then we negotiated for the salary advance loan. And then at a point, this scheme went to sleep. Many a times, you get some of these newly recruited nurses coming on board because of their delayed salaries. How can I get a loan from the association? And then once they are not dues-paying members, it becomes difficult to give out the loans. Thankfully to your very self and the loans committee, we now have the ADB GRNMA policy. I believe this is an avenue to get most of them to our side. When they are newly recruited, we can have a new policy that can give a limitation to an amount for them to start with. Indirectly, we are getting them at our side. We need to speak with the Controller and Accountant General's department so that once we are giving out these monies to them, automatically they become members of the association. And then we can get majority of them on our side. Thank you very much.
Thank you so much for your suggestion.
Thank you very much, Madam President. My name is Gracious Jabro Nadoli Kaliu. My concern has to do with our members that furthered their education in courses outside nursing.
most of them, when they come back and the other unions transfer them to themselves, they wish to come back, but I don't know, it's becoming a challenge. I've submitted some data as of now, we are still following on them. So I don't know how we are going to do to get those members who wish to belong to the association, even though they have moved on a different profession. Thank you.
Thank you very much. We will need to discuss that further.
Thank you. My name is Regina Kweku, delegate from the Western.
Push the mic down.
Delegates from the Western region. With the issue on how to grow our membership, I think with the support of leadership and all of us, we should try and find lasting solution to the situation that goes on at controller and accountant general. When new entrants are in our facilities, personally, I help them to fill their IPPD form. I would rather choose GRA naming for them, but when their salaries start coming, some will report that, oh, Sister Reggie, my thing has gone to other unions. So if we could find lasting solution to that problem at the controller accountant general, that they are taking our members away, it's also going to retain those ones that the new entrant that we add on to membership. And again, we should also try to let the rotational nurses and our junior nurses see what the association has done in terms of letting them visit our various secretariats in the regions. When they see it, they are happy about it. Also, when I join you, this is what our dues is being used for. I can come and lodge here, I can have my wedding reception here and other things. So if we continue with the advocacy, I think we'll get more of our members and retain them.
Thank you very much. On the first point you raised, please, we've had such events in the past, and controller has been kind enough to revert everything back to us. The most important thing is to create the evidence. Once the IPPD form is given to another union, we collate all, and controller is always willing to reverse it all. But if it's difficult when you don't even have the evidence to speak to, you can't go and tell the controller just by word of mouth that I had this, I had that, and it didn't work. So create that evidence for us, and we'll be able to do a lot with it. Thank you. And that's the last one. Last one, and then we move to the next pillar. Yes.
Good morning. Good afternoon. My name is Nancy Oduro from Greater Accra. On our membership drive, I would want to ask, has the association really wanted to find out what our members want from the association? Because if we should do all these things just to get more members, very soon those are asking us to pay their school fees for them. So I think we should really ask our members what they want for, because the other association, not necessarily with nursing, you don't hear them doing these things you are doing, but they have their members with them. So the question we should ask ourselves is, what can we do to make sure that our members remain with us? Because you do this, and then 5 years they are employed, and association comes to take them from us. Okay, so let's ask ourselves what other associations are doing to keep their members with us, of doing all these incentives to, drive our membership. Thank you.
Thank you. Thank you for your contribution.
Hello. Good afternoon, Mrs. President. Please, I would like to touch on the last line, the strategic plan there. They talk about discounts, offer of discounts. It's not well understood. Scholarship and all that. Is it that when you have...
They came from... Okay.
Yeah. Is it that a discount on the dues, or if you have paid dues for so many years, 20 years and above, you have to be relieved of your dues for some time before you continue, or what discounts? All right.
To be frank, this is the first draft. Like I said, this will allow you to make inputs, but it's not the final document. We'll have to go back and really look at the issues. some of the strategies you are seeing here are inputs from some of you here. When the survey went out, you put in these scholarship discounts and so on and so forth. We are yet to really understand what you even meant by it. It's not coming from us. It's not coming from us. It's from the surveys and the data that was collected. So we will probe it further to understand. As for scholarships, I've answered that question already, and it cannot stand. We don't provide scholarships for members. The employer needs to sponsor you to go to school. Are you in the line?
Oh yes, I was the last person to. Thank you, Ideas Coleman Adato. I'm here to provide one point of information. We have students and rotation and awaiting employment, platform on the Infonet. And we have publicized this severally, only that the information is not getting to our colleagues. Yesterday at the luncheon, I met some GIMTA
Use the mic so that they can.
I met some GIMTA people here, and I was asking them if they were on our system, if they buy data and the rest. They said no. So I took them through the registration. And it's a very simple process. *928*10# for students, and every district chairperson or secretary knows this. So if you are in a district and somebody or students or rotation nurses are working in your district and they have not subscribed to be part of the system, then we have to blame ourselves. Because we at the district level, we are the gatekeepers. The students come to us, so we have to recruit them. If we want to throw everything to national, go to controller, go to IPPD, it will not work. We have to start at the various districts and the various facilities. Secondly, I want to make this point. I think that it's about time the association has some award scheme for districts that are having the highest growth in terms of their numbers or percentages on the system. Because some districts are doing extremely well, that every month on month when you check, there is a growth, there is a positive growth. Whilst others, you are not seeing any growth. So for example, for Greater Accra, for instance, we are having over 18,000 members. Meanwhile, we are not the region with the highest number of nurses. But in the system, we are the region with the highest number of membership. And I think that we have to be commended for what we are doing for the association. Thank you very much.
Okay, so we have 260 districts. If the suggestion is to use, I think we can discuss further at national executive level. If we are using the Infonet, and the only index we are using there is growth in numbers, the question is, will it be enough to base on growth in terms of membership and say that we are awarding? And the truth of the matter is, we cannot also put in a system in reviewing all the 260 districts to say that we are. I think that it's about time the regions can start looking at something. You know them better. You work with the districts, and you can use some parameters to evaluate them and make a determination that within this year, these are the top 3 districts in the region. Once you start something, maybe in time, not now, but in time, national can pick it up. But at the moment, it will be quite difficult. It will be quite difficult for us. We'll take the last pillar. Partnerships and collaborations. Any input here? Any question? Great. Great. Thank you so much. So, you want to speak on this one? Okay. Please go ahead.
Thank you so much, Madam. My name is Emmanuel K. Abiu is my name from Greater Accra. The first point, partnership, I still want to make a point as far as the awards are concerned. I think GRNMA have been doing so well awarding ourselves. Do we consider going into partnership with government as they have been doing for NAT? Is it that they are not considering our importance for us to have a national best nurse or midwifery midwives award for us as they've been doing for the teachers? We also need the 2-bedroom. We also need the pickups. Let's work with them to get this done. Thank you.
Okay, so you recognize the fact that, was it in 2021? We established the awards in 2020. And I think in 2021, the Ministry of Health also picked it up. Madam Evelyn is here. And they started giving awards. Aside the Ministry of Health awards, the Ghana Health Service also started. And they are awarding all health workers, but the majority of awardees are always nurses and midwives. So I think we can advocate through the Ministry of Health to engage the cabinet on this and see how they can elevate the Ministry of Health award to that level. As far as we are a trade union and association, we will do what we need to do. And since 2020, we've been given these awards. Resources are not only from the coffers of the association. We have great sponsors who continually stand by our side and support us financially. So even with the first award, it was Carl Bank that actually paid for the vehicle in 2020. But since 2021, the resources we pull together, we get the vehicle and get the other award. So we have partners who are working with us already on that. But if in terms of the national, that's the role the Ministry of Health is playing. They can take it a step further if they want to do it the way they are doing for the teachers. Yes.
Thank you, Madam President. My name is Jefferson Asari Dankwa. My question is in relation with partnership with other institutions such as Nursing and Midwifery Council. Madam President, that institution, which is supposed to be our regulator, has been one of the greatest challenges of nurses in terms of corruption, in terms of delay.
Please use the word alleged.
Thank you, Madam President, for the correction.
Alleged.
Thank you, Madam President, for the correction. Alleged corruption, delay in renewal of PINs, certificates, and verifications. Madam President, I want to understand what level of collaboration is GRNMA having with NMC, and how would we resolve these delays in the PIN renewals, certificates, and alleged corruptions? Thank you.
Tomorrow, right after this session, there's a panel. NMC will be represented on the panel. So we are not answering this one. I'm sure the representative will have something. She's already seated here. I'm sure she's heard. But what I can say is that I sit on the board of the NMC, but it's more about helping the NMC in its strategic direction. And alleged corruption has not been tabled, and I don't know what it is that you are talking about. Delayed PIN renewals, yes, we are aware of some delays in the regional offices. So, like I said, in the next panel, we are looking at outlook of nursing and midwifery, and it will give us opportunity to discuss some of these matters further. At this point in time, we've tackled all the pillars, and I want, on behalf of the whole National Executive Committee team, say a big thank you to you for sharing your thoughts with us, and we'll go back after this conference, finalize the documents, and when it is fully completed, we'll put it on the infonet so that every member can have access to it. On this note, I want to crave your indulgence that you give yourselves a huge round of applause. And this one is for you. The next one is for our consultant who has done a yeoman's job here. Thank you so much, Dr. Segla, for your time. We are zooming straight into the next session. Chairman is shaking his head vigorously. Burnout. So, Chairman, okay. All right, so we are advised to go for lunch at this time because lunch is ready, and you were not given opportunity to go for a snack break. So, but they were served snacks here. Okay, so we are going on lunch break now. It's 1:37, and we are coming back. Okay, please be seated. There is further announcement. I'm actually going to hand over the microphone to our host chairman. He's going to give us details about the lunch arrangement and other things. Thank you.
Thank you. So lunch is ready, and to avoid the overcrowding, the lunch has been packed. We have 4 dishes on the menu. We have